Good evening, everyone. And for those of you who are joining us from the far corners of the Western world, good morning, good afternoon. Welcome to this webinar on bone turnover markers and biochemistry for boneheads, organized by the Osteoporosis and Bone Metabolism Unit at Singapore General Hospital, which I'm proud to say is the only such unit exclusively devoted to the clinical care and research of metabolic bone disorders in Singapore. Our tiny little unit has been organizing these educational events since 2007 when we first set the unit up. And our last major conference was in 2019 when we had the first Asia Pacific Skeletal Rare Disorders course and the first Singapore Metabolic Bone Disease Symposium in 2019. Now, we've absolutely been floored by the response to this webinar. We were expecting only about 25 to 50 people to show up, to sign up. And we are absolutely thrilled to see the final attendance, which is close to 400. And that too from all corners of the world, from Brazil to New Zealand, from the US to Japan and everywhere in between. I would like to pay a special welcome to the many Australians who have joined us, despite it being ANZAC Day there in Australia. So thank you all for joining, and it's my pleasure to actually welcome all of you, as well as introduce the two internationally renowned speakers that we have managed to get to speak to us today. And I will be introducing them in a second, but before that, just a couple of housekeeping issues. We had to actually close the registrations when it hit a certain number because we were just inundated by the registrations. But all of you will be muted, as well as your videos will be off during the entire webinar. So get your coffee and get some snacks, because it's going to be an intense 3 hours of bone biochemistry for all of us boneheads. You can please do type your questions only into the Q&A box. Please do not enter it in the chat box, because I cannot be kind of looking at both the Q&A as well as the chat box. So please enter your questions only into the Q&A box. The program is, like I said, is intense. It's for the next 3 hours. We'll be listening to various topics within this very unique and rather esoteric area of bone turnover markers and bone biochemistry, as well as estimating renal function. So with that, let me introduce both speakers, one after the other, and then they will commence their talks. After each presentation, there will be a short 5-minute Q&A. And then, of course, at the end, we have arranged for, hopefully, we will have time for it, for a half-hour challenging case discussion, as well as the remaining questions which were not answered during the initial presentations can be answered then. So with that, let me introduce the first speaker for today, Professor Etienne Cavalier. Etienne is a very dear friend of mine, and I'm privileged and honored to have him with us today. Etienne Cavalier is head of the Department of Clinical Chemistry at the University Hospital of Liège, Belgium. He graduated as Master in Pharmaceutical Sciences in 1994, and he got his Advanced Master in Clinical Biology in 1999 from the University of Liège, which allowed him to be recognized as a European specialist in laboratory medicine. And he obtained his PhD thesis also at the University of Liège. Now, Etienne's repertoire is extensive. He is a world-renowned expert in several areas, including bone markers, vitamin D, PTH, vascular calcification markers, markers of acute kidney disease, glomerular filtration rate, and markers of frailty and sarcopenia, as well as liquid chromatography, mass spectroscopy methods with steroids and peptides quantification. He is the president of the Royal Belgian Society of Laboratory Medicine and is a chairman of the IFCC IOF Committee for Bone Markers. He is also a member of the board of the APCO, which is the European Society for Clinical and Economic Aspects of Osteoporosis, Osteoarthritis, and Musculoskeletal Diseases, and of the Belgian Bone Club. He has won numerous international awards, including the 2021 Excellence in Performance Specifications Research Award from the European Federation of Clinical Chemistry and Laboratory Medicine, which is EFLM for short, and the 2022 SKO Medal of Excellence. And I'm proud and privileged to consider him as a very dear colleague and friend. So equally important and equally well known, and another very dear friend of mine is Dr. Samuel Vasikaran. Dr. Vasikaran is a consultant chemical pathologist at Pathwest Laboratory Medicine, Western Australia. He has a special interest and expertise in bone turnover markers. He has multiple publications, more than 130 peer-reviewed publications and book chapters just in that area. Dr. Vasikaran actually chaired the IFCC and IOF working group on bone marker standards in 2011, which in collaboration with the IOF IFCC designated serum P1NP and CTX, which we now commonly use as a reference bone turnover markers in osteoporosis. He's currently a member of the IFCC Committee on Bone Metabolism, and Sam is a wonderful gentleman and dear friend. So welcome both of you, and I will now kind of hand over or shine the spotlight on Etienne Cavalier, or Professor Cavalier, who is going to deliver his first talk, which is going to be on a topic which is very dear to his heart: PTH and vitamin D, the measurements and their measurement. Etienne, over to you.
Thank you very much for this very kind introduction, Manju. Let me share my screen right
Perfect.
now. Okay, I hope
Sam
that
and
you
I
can
will
see.
mute.
Okay. So good morning for me, everybody, or good evening. I'm very proud to be part of this very interesting webinar today. And I'm very happy to give these 4 lectures on vitamin D and PTH. So I will start with vitamin D. That, of course, you know pretty well. What vitamin D comes from D3 or D2. D3 is the one that we synthesize when we expose our skin to the sun. We can find also D3 in food, whereas it's more complicated to find D2 in food. But you can find both as complements, so for vitamin D supplementation. So either D2 and D3 get into the circulation and then get the first hydroxylation in the liver to give what very well-known 25-hydroxyvitamin D2 or D3, which is the metabolite that we usually measure to evaluate the stores of vitamin D. So the half-life is quite long, and both D2 and D3 should be reported as the sum of both moieties. But you also know that the 25-hydroxyvitamin D is not the active metabolite. The true hormone is 125-dihydroxyvitamin D2. And the transformation of 25-hydroxy-D to 125 is tightly regulated by the 1-alpha-hydroxylase of CYP27B1, whereas the transformation of vitamin D into 25-hydroxy-D is not so much regulated. Of course, you know that this 125-hydroxyvitamin D has got the classical endocrine genomic effects, but it has very short half-life, but it's really the true hormone, and it circulates at concentrations which are 1,000 times lower than 25-hydroxy-D. Very importantly is also the pathway of the vitamin D degradation, which is achieved through CYP24A1, which is a 24-hydroxylase that transforms 25 into 24-25 and 125 into 124-25 trihydroxyvitamin D. And this is really the way we can eliminate vitamin D. And this elimination is also tightly regulated by different hormones like FGF23, 125 itself, and so on. So this is something that is gaining more and more importance, as we will see later during this presentation. So now the big question is, of course, what should be the appropriate 25-hydroxyvitamin D concentration? This is a $1 billion question, of course. And you can see that the experts do not really agree. For some of them, the correct concentration should be above 10 or 25 or 30 nanomole, whereas many experts consider that this should be above 50 nanomole. Some experts consider this should be 30 nanograms, so 75 nanomoles, and even there are a few persons that consider that 25-hydroxy vitamin D levels should be above 100 nanomoles. I won't like to discuss this because it could take a couple of days, but the only thing that I want to mention is that when we talk about defined cutoffs, whatever the cutoffs are, it means that all the assays that are providing these results should be standardized to provide the same results. Of course, if it has no meaning to talk about cutoffs, if methods are not standardized, and this is really important. And then I turn into vitamin D assay standardization, which has been a very important things that started early by different societies, scientific societies. Of course, there was the NIH, the ODS, the CDC, the DQAS, the CAP, the IFCC. All these scientific societies started to work on improving vitamin D, 25-hydroxy vitamin D standardization for 4 years. And now I would like just to go not too much into history, but just to present you the results of the DQAS after this standardization efforts. At what you can see here is 2018. Is that now we've got a target, a true target that has been determined by a reference method for those external controls. And you can see that, of course, there will still, and you will always have discrepancies between the different labs, but I can really tell you that it's really has been reduced compared to what happened before the standardization. And you can see here that, for instance, the immunoassay that I was using there was slightly biased to the right. I also like to mention here that these are in the gray here, these gray bars correspond to tandem aspect assays. Many people think that tandem aspects are the gold standard methods. And when I'm reviewing papers, I often see people say, well, we've been using tandem aspects, so we've been using the gold reference standard method, whatever you call it. But here I would like really to point out that tandem aspect users that you can see in gray do not really perform better than immunoassays. And there is also a very big difference between those labs using tandem aspect having a value of 52 nanomole and this one having 100. So it's not, the message of this is this, that it is not because you're using a tandem aspect that you've got the gold method, reference method in your hands. I mean, there can be lots of variations, so of course with tandem aspects, and this should be really taken into consideration, that tandem aspects are assays just like other assays, and if you do not handle it properly, you will come to wrong results. So the impact of vitamin D standardization program really have improved the bias observed between the reference methods and the different methods that are available on the market. But unfortunately, this has not been totally resolved. There are still issues with immunoassays, and there are also issues with tandem aspect, as I've shown you. And there are also some unresolved problems which are remaining. I would like then to switch to 125-hydroxy vitamin D determination, just really to state that this should not be used to evaluate vitamin D status, because as I've shown you earlier, the regulation of production of 125 is very tight by PTH, FGF23, 125 itself, and so on. It circulates in concentration which are 1,000 times lower than 25-hydroxy vitamin D. So we should not use it for evaluating the vitamin D status, but it's a very important analyte, metabolite, but in very clinical specific situation, just like here by exploration of non-PTH mediated hypocalcemia, in exploration of different the rickets, and in the tumor-induced osteomalacia. So it's very important, but in very specific situation, and we should not have so many requests for 125 dihydroxy vitamin D in clinical labs. Problem with 125, besides all this, is that also there is not so standardization. There is no reference method for 125 so far, and you can see a huge distribution on the concentration obtained by the different labs, which magnitude of above 5. So it's a very complicated analyte. So that should be really restricted to very specialized labs in very specific situations. So this being said, I would like to switch to some clinical cases with vitamin D and ask your opinion about this clinical case that I recently had about a girl of 2 years old, which was born in Belgium from Congolese parents, and she was born at 35 weeks. She has a minor thalassemia. She has a 4-year-old sister with in good health, but this little girl has some difficulties to walk and to eat. Her height and weight is lower than the 5th percentile. And at the time that she had the first blood sample, she underwent neurological exploration for muscle weakness. So here are the results that we obtained in our laboratory. You can see a low concentration of calcium of 1.70, low phosphate, very sky high total alkaline phosphatase about 5,000 units, 25 hydroxy vitamin D that was at 17 nanomole, should be above 50. Her PTH was at 106 picogram per ml. If you are working picomole, you have to divide this by 10 around. And there was the lab note reference range for children, but adults, the reference range was 10 to 65 picogram per ml, so high. She had a very elevated 125 dihydroxy vitamin D at 1020 nanomole per liter, and she had undetectable 24-25 dihydroxy vitamin D. I guess that you see what this little girl had. This is a picture of this very highly bending and demineralized bone. So this girl really had rickets, even here in Belgium. Of course, we don't have so much sunshine, but with people that present a very dark skin, and this little girl had no the dairy products in her food. She only eats pasta, and there was big issues. So rickets is still present in our areas, and we should take care of this and be, of course, no explore those patients for muscle weakness when it's rickets. I would like now to switch to another case, which is the case of this 45-year-old females that underwent a general checkup in our laboratory. So she's got normal hemoglobin, she's got no CKD, she's got normal calcium concentration, she's got normal PTH concentration, but with an immunoassay, we obtained 25 C vitamin D above 300 nanomole per liter, which was quite strange, because when the physician asked the patient, this lady said that she did not take any vitamin D supplements. She never went to sun-tanning bags. So we had no really explanation why this lady had so high 25 C vitamin D without any explanation and without any apparent reason. So what we decided to do was to retest this 25 C vitamin D with another immunoassay, or you can also do it, of course, with a thermal spec. And the result came to be completely normal at this value of 60 nanomole per liter. The point is that, of course, what we observed in this case was a clear interference by heterophilic antibodies that gave a falsely elevated 25 hydroxy vitamin D concentration. This is really one of the main limitations of the immunoassays, is that each time that we are working with immunoassays, we have to consider that these immunoassays can have interferences due to heterophilic antibodies. This is not so much the case, of course, of Tanemaspec, but of course Tanemaspec has also other disadvantages, like, of course, needed an experienced staff, an expensive equipment, and a more limited throughput. Then I switched to this very interesting case also that we had in 2020 of a 61-year-old patient that was hospitalized with a weight loss minus 10 kilograms and acute renal failure. This patient had been taking 800 units of vitamin D for several months. And on the admission and in the emergency ward, he was highly hypercalcemic at 4.20 millimole per liter with totally reduced PTH concentration. His PTH-RP was negative, and his 25 hydroxy vitamin D was at 190 nanomole per liter. This patient was normocalciuric. He had no renal stone. He had lumbar osteoporosis and osteopenia, and there was no neoplastic lesion on the PET scan. So we decided to go on with the exploration. So of course that the physician started to treat the patient, and among the extra investigation we decided to measure 125 dihydroxyvitamin D, which was also sky high, explaining probably the hypocalcemia at 400. We also measure FGF23, which was quite elevated at 284 picogram per liter. And then we decided in face of that to understand why this patient had so high 25 and 125 dihydroxyvitamin D. We decided to measure the 24-25 dihydroxyvitamin D3 beta mass spec, and this was totally reduced at a value of 0.16 nanomole per liter with a vitamin D metabolite ratio, which is the ratio between 24-25 on 25 multiplied by 100, which was totally decreased of 0.1. So to explain this, when we went to a genetic testing and the genetics testing suggested there was a mutation in this enzyme that is supposed to degrade the 25 and the 125 dihydroxyvitamin D. So this patient had really endogenous or exogenous vitamin D intoxication, but while taking only 800 units of vitamin D. He was treated by rifampicin and of course no more vitamin D at all, and the patient now is perfectly well. Of course, this mutation of CYP20, these mutations of CYP24A1 drive to disease in kids, which is idiopathic infantile hypercalcemia, which has been described for a long time but published in the NEJM in 2011. And this really has to be a disease that should be taken into consideration also, of course, in adults presenting hypercalcemia with elevated vitamin D levels while not taking a huge amounts of vitamin D. This is a paper that we published in CCLM in 2020 in 1,200 children in whom we measured the 25 and the 24-25 the dihydroxy vitamin D. And what is really interesting is that when you see those children which present quite low concentration of 25 hydroxyvitamin D levels, these children do not really start to produce, most of them do not produce 24-25, showing that maybe from a biochemical point of view, when there is insufficiency of 25 hydroxyvitamin D, you do not start to degrade the metabolite. But once you start to increase vitamin D concentration, then you start to increase the activation of the CYP24A1 and above 20 nanogram per liter, 50 nanomole per liter. So those kids do not present, most of them do present 24-25, just showing that maybe that the level of sufficiency should be there. But between 10 and 20 nanogram per ml, there are kids that start to degrade or not, showing that maybe there is not one size fits all cutoff for vitamin D, but maybe that it's more a personalized medicine that we should achieve for the good vitamin D levels. So this ratio is really important, and unfortunately there are different calculations of the vitamin D metabolite ratio. We do really prefer to use this ratio, which is 24-25 above 25 multiplied by 100. The range should be between 4 and 12%. Let's switch now to another question to you about this 51-year-old male from African descent with a general health checkup. He has normal bone mineral density. The question is, when you look at this result, his 25 hydroxyvitamin D is lower than 15 nanomolar, which is the common cutoff that we are using. So the question is, should this person be supplemented with vitamin D to increase his level above 50 nanomolar per liter, just like we generally recommend for every individual? If we measure the 24-25 dihydroxyvitamin D in this person and the vitamin D metabolite ratio, you can see that it's perfectly normal. And this is really interesting because we know that people from African ancestry, they present lower 25 hydroxyvitamin D concentration compared to their people from European ancestry counterparts, but for the same concentration of PTH. But when it turns to compare the vitamin D metabolite ratio, you can see that it's exactly the same between white and black people, and then the vitamin D metabolite ratio might be, this is something that is really interesting, might be a better indicator of vitamin D deficiency, and especially in people from African ancestry. This was from the United States, but we can also have that here in Belgium, with people from African ancestries and from white Belgian ancestry. You can see that, of course, they've got lower, these black points have lower vitamin D concentration, but the VMR remains the same. And those who are really deficient have a low vitamin D, 25-OC vitamin D, and a low VMR. So 24-25 is very interesting, but cannot be measured so far by immunoassay. You can only measure it by 10 mass spec and by a good 10 mass spec. I would like to end with this for vitamin D, with this very interesting clinical case also about a 9-month-old girl from European ancestry admitted to emergency department for constipation and sleepiness. And you can see that her creatine level is very elevated for a young 9-month-old girl. She's very hypercalcemic with decreased PTH and 25-OC vitamin D with an immunoassay obtained at 105 nanomole per liter. The radiography shows signs of nephrocalcinosis. Going back to the family, her mother is an engineer, so a very smart woman, but she's also vegan. And when she's been asked by the physician, she mentioned that she was giving exactly 5 drops of vitamin D to her child every day, as it was mentioned on the leaflet of the drug. So contacted the pediatrician contacted us and asked for extra investigation to the lab, and it was sent to a lab that was performing another immunoassay. And you can see that with this other immunoassay, the value was not at 105, but 310 nanomole per liter. And when it was put on a 10 mass spec, the problem was that the 25-OC vitamin D3 was at 55 nanomole per liter, but the 25-OC vitamin D2 was very elevated at 280 nanomole per liter. So the problem with this is that the drug had been purchased in a so-called vegan shop, and basically each drug contained 10,000 units of ergocalciferol, which is vitamin D2, and not 100 units as it was mentioned and supposed to be. So the problem here is that the first immunoassay did not really cross-react correctly with 25-OC vitamin D2. And this is really important to use good tools that can detect 25-OC vitamin D2, even if it's not the major drug which is given as a supplementation. This can be found, and this is not this drug, or these are not drugs, but these products that you can find in non-controlled shops or not controlled pharmacies, or there can be issues in the concentration they have. And really in this case, there was a big issue because this little girl was intoxicated by D2. So now I would like to, I'm sorry, it's a bit fast, but I have lots of things to say. I would like to switch now to parathormone and PTH. I would like just you to understand there are 2 generations of assays which are available on the market. And just to remind you about PTH, that is this 1-84 PTH peptide, which is biologically active and needs to be completely 1-84. There are large fragments that are circulating in the circulation that are accumulating in chronic kidney disease. But these are aminally truncated fragments. There is also lots of truncated fragments, and there is also in the circulation in some patients suffering from very severe hyperparathyroidism or also parathyroid carcinoma. There is a post-translationally modified form which is called amino-PTH, which is supposed to be PTH modified on the serine in position 17. This is supposed to be a phosphorylation on this serine. The second generation PTH assay, which is also called intact PTH assays, recognize, of course, the 1-84 PTH, and also are supposed to recognize the large C-terminal fragments that can accumulate in the serum of CKD patients. They do not cross-react for most of them with the amino-PTH. Whereas the third generation PTH assays, you can see here that they use an antibody which is targeted against the first 4 amino acids of the peptide. So these assays, of course, recognize the 1-84 PTH. They do not recognize the large C-terminal fragments, but they can recognize the amino PTH, and they will be much higher in patients suffering from a parathyroid carcinoma. Just to give you, from a clinical perspective, in the guidelines on the management of primary hyperparathyroidism clearly stated that you can use either second or third generation PTH assays for clinical use. It's important, but then to have the appropriate reference ranges, as we see later on. And this is so both are clinically relevant, and there is not so much clinical advantage of one over the other. The big problem about PTH assay is the standardization, one of the big problems. And with this editorial award, what does a PTH of 300 picogram per ml actually mean? Because when you go to nephrology congress, you hear nephrologists talking about this patient having 200, 400, 500. What does that really mean? And to try to explain this, my friend and mentor, Jean-Claude Suberbiel, published in 2006 a paper where he sent samples to be measured by most of the methods that were available in France at that time. And you can see that between the kids giving the lower concentration here at 83 and those giving the higher concentration, there was a magnitude of 4. Whereas at this time, we were trying to focus patient, to concentrate patient between 150 and 300 nanogram per liter. Of course, this means nothing when you say this patient and 300, it could be 160 with this kit, but this could be 600 with this one. So this is really a big issue on PTH assay standardization. And it was 2006, and this has not been improved with the next year, because you can see with the Belgian control here, you've got also these very big discrepancies between those kids and these kids, giving a very big difference between the values obtained with those PTH kits. The problem is that we can see with this UK NIQUAS control for PTH, you can see that the third generation PTH assays are correctly, I would say, calibrated. Again, the WHO international reference standard on PTH, basically with those kits, which are either the Liaison Diacerin Fujirebio or the Roche Alexis assay third generation. When you have 100 picogram of PTH, well, those kits give you 100 picogram of PTH. But with those immunoassays from intact PTH or second generation PTH, if you have 100 picogram of international standards, those kits can give you 200 picograms. So there is a 200% cross-reactivity, which is totally, of course, unacceptable. There is no reason why these kits give you 200 when they should give you 100. So there is a big issue in standardization of PTH, and that's what we are trying to do also with Dr. Vasikaran, that is in the board of the FCC committee. We're trying really to promote the standardization of PTH assays, and because it's a headache for clinicians to try to play with those problems. And of course, we've got international standard for PTH, which could be used, which should be used. And also, we really had the chance to publish a candidate reference method for PTH in clinical chemistry last year with my PhD student, Jordi Faré, where we could really, this is the time aspect determination of PTH at 32 picogram per ml. You see that big, very nice peak of 1 to 84 PTH. So now, this is really a very important step to promote the standardization and to force manufacturers to standardize PTH assays. A few words about amino-PTH, because I know that there are endocrinologists among you. And amino-PTH had been described in 2007 in clinical chemistry by Dr. Rubin and Professor Etienne as a form that was overproduced in parathyroid carcinoma. And as I mentioned earlier, this amino-PTH is recognized by third generation PTH that recognize 1 to 84 and the amino-PTH, but it's not recognized by second generation PTH that supposed to be recognized 1 to 84 and supposed to be 7 to 84 or big non-1 to 84 PTH. So basically, amino-PTH should never be found in healthy individual or in normal patients. So this ratio should always be lower than 1 because, of course, this is not present. But the literature that had shown that this amino-PTH is overproduced in parathyroid carcinoma. And if it's overproduced, of course, this ratio becomes higher than 1 because of this overproduction of amino-PTH in the patient. And we published 2 papers in JCNM showing the interest of this ratio in parathyroid cancer. Just to explain you on this slide, these are healthy people, renal transplant patient, hemodialysis patient, parathyroid adenoma patients where the ratio is lower than 1. But you can see that in this cohort on 24, parathyroid carcinoma patient, you see most of those patients presented an inversion of the ratio, really showing indirectly showing that the presence of amino PTH that was overproduced in those patients. So the problem is that that was achieved with diacerin assay, but diacerin changed the standardization. And now I do really believe that we are working on determination of amino PTH by TAN mass spec, and I hope that in a few months we'll be able to come with a real publication of the real determination of amino PTH by TAN mass spec. That will be an improvement for the care of patients suffering from parathyroid carcinoma. Just a short clinical case about this patient. This is a very basic clinical case that has 75 years old woman, normal calcium, normal creatine, normal vitamin D above 50, and PTH at 51 picogram per ml. What does that mean? What are the reference range for this PTH? And this is really a big question. How do we establish reference range? And this is important because we as lab people, we follow our guidelines that say that we should verify the manufacturer's reference range. But the manufacturers in their IFU, they say laboratories should establish their own reference range, which is totally different. And when you look how to establish correct reference range, you have to take into consideration that you do not include patients suffering from CKD. You should include patients that are not vitamin deficient. You should take into patients that have normal calcium PTH levels and also normal calcium intakes. Basically, of course, when you want to establish good reference ranges for PTH, you should avoid any condition of primary or secondary hyperparathyroidism. The problem is that most of the manufacturers have never used those criteria to calculate their reference ranges. So they possibly included patients suffering from secondary hyperparathyroidism or even primary. And also, an important thing is that most of these reference range have only been established in participants from European ancestry. There is nothing about people from other ancestries. And that's what really proved in 2012, where we compare on 120 healthy males, 120 healthy females, the reference range of the manufacturers and the reference range that we produce, taking into consideration the different parameters that I just mentioned earlier. And you can see that for some immunoassays, for instance, for this one, the manufacturers claims an upper reference limit of 88, whereas we found it to be 50. And it was the same for many others. And even with the Roche, which is supposed to be 65, when you look at the upper limit of reference, it's 50 picogram per ml. So this is really important that you should really have good reference range to correctly interpret reference PTH, and of course, until there is standardization of assays, it's important the laboratories mention on their protocols the methods they use for PTH determination. I really insist, this is really for lab people in the audience. Maybe that you do, I don't know, but if you don't, please do mention which PTH assays you are using so that the clinicians can really compare apple with apples and pear with pears, because for the moment, comparing PTH assays, just comparing apple and pears until everything is standardized. Now I come with this clinical case of a nurse working in our hospital. This is once again a case that we published. She was known to suffer from hypothyroidism. She was treated and she was coming for consultation for a prescription of her thyroxine. And here are the results that we found. Everything normal, every vitamin D normal, but 210 PTH concentration. The upper limit of reference with this assay was 72. So hyperparathyroidism, but no real evidence to understand why she had this elevated PTH. The problem is that, again, this was an interference. Just to say, we are using immuno sandwich method for immunoassay. So there is one antibody that captures the analytes, one that binds on the other epitope on the analytes and gives the signal. But sometimes patients present heterophilic antibodies that can they bind both antibodies, and you've got a signal, but there is no analyte there. And this is really a very tricky interference, but this is important to really take into consideration. And the real answer that this patient has human anti-gout antibodies that interfere with the PTH assays that was using anti-gout antibodies. So this is something, a lab error, but again, the clinician should talk with the laboratories, because interferences immunoassays are very frequent. Heterific antibodies, rheumatoid factor, monoclonal immunoglobulins, complexation with immunoglobulins like macroprolactin that you probably know, but you've got macrotropin, macro TSH, which reduce the clearance of the hormone and then falsely increase the concentration. Many interferences with vitamin B12 assays with falsely elevated vitamin B12, and I would like just mention with interference with biotin, but I think that manufacturers have really improved that. So again, big message here: do not hesitate to call the lab to perform extra analytical investigation when you've got the feeling that the result does not fit to your clinical feeling. So I will end now with my take-home message for PTH. Second and third generation provide the same clinical information. There is unfortunately so far an important lack of standardization of PTH assays. This is ongoing. We are trying to do our best to really improve that, because we should not put the burden of this on the shoulders of clinicians. And we are really working with the FCC to improve this. I hope I also convinced you about the importance of the reference ranges, of the future of the importance of the post-translationally modified forms. And again, keep your feelings and contact the lab if you've got an hesitation of any interference. For vitamin D, the standardization is something that has been already done, and it has really improved compared to 10 years ago. Pay attention that ThermaSpec is not necessarily the gold standard, and you can have big issues with ThermaSpec. And I do believe that 24-25 may become in the future a very interesting analyte for this estimation of vitamin D deficiency. And I would like to thank you for your attention. I will be happy to answer your question. I'm sorry for the speed of my talk, but we had lots of things to say in a very short period of time. Thank you very much.
Merci beaucoup, Etienne. Really, okay, c'était un tour de force. Really, that was a tour de force. It was phenomenal. I can't imagine how you were able to give us so much of information in such a short time, and fantastic. I really cannot thank you enough. And you are pretty much close to time too. I mean, you're amazing. So we just have a couple of questions, maybe, and maybe I'll kind of. So there are a couple of questions. One of them is on the role of vitamin D binding protein levels. Do you check them, or is there any situation in which you would check vitamin D binding protein levels?
But vitamin D binding protein is fascinating, but you know, there is a big polymorphism, and then there is this trend showing that maybe it's the free vitamin D that should be used. But well, I'm not using vitamin D binding protein in routine. We do that for clinical for research purposes. Maybe to evaluate with a calculation to evaluate the free vitamin D concentration. There is, well, I believe that free vitamin D should be determined by the ThermaSpec, and there is a couple of papers that are going on this. But really, we know that vitamin D binding protein can, well, in pregnancy, for instance, there's an increase of DBP that can have an impact on the 25-hydroxy vitamin D assays. There are some issues, of course, with the polymorphism, but it's very difficult. Besides calculating the free vitamin D, I do not really use it in at least not in clinical routine.
Okay, I mean, the reason why that's actually a question from me, because I mean, you know, recently I had a consult from a doctor in Indonesia who was asking me about this patient who has been supplemented really adequate levels of adequate doses of vitamin D, should not have any evidence of any malabsorption kind of problems. And despite that, her 25D levels remained abysmally low. And I actually kind of said, look, I mean, if that's the case, then maybe there might be a role for checking vitamin D binding protein in that case, and maybe even checking for the gene, the group specific component gene of vitamin D binding protein. So that's the reason why I asked that.
Yeah, I
now,
understand.
There is another question from Mani Nenke, who asks, what levels of 25 and 125 vitamin D would you expect to find in sarcoidosis, where obviously macrophage is producing 125D. I presume that's where she's coming from.
Yes. So of course you're expecting to have an increase of 125 in those patients, and of course maybe a small decrease of 25. But you know, Benami, that unfortunately it's not always so clear. You expect to have an elevated 125. Not all the time, but if you've got an elevated clinical suspicion of sarcoidosis with an elevated 125 and maybe a hypocalcemia, then you get it. But this is one of the rare cases where we should measure 125 in the clinical suspicion of sarcoidosis, tuberculosis, and so on. So it should be elevated, yes. But it's not so obvious. It's not so obvious to have, because again, it circulates. It's in very tiny concentration. We have shown you the assays. There are some issues with the assays for 125, and all the assays are not very good. You can also measure it with mass spec, but it's very complicated too, to be very frank. So it's a very tricky measurement, 125. But in sarcoidosis, going back to question, I suppose it to be elevated. Yes.
Okay. And I do request the attendees to actually type their questions into the Q&A box. I just happen to see the chat, but which may not be the case all the time. So someone has asked whether we have data comparing, I presume, 25D levels between whites and Asians. Is there any kind of data to show the differences? I know you said blacks have lower levels of vitamin D.
Yes. Well, it's blacks because we discussed this with the GFR topic later on, but because there was this polymorphism, and of course that people from African ancestry they've got, even if they got lower 25 vitamin D, they've got stronger bones, which is quite paradoxal. But this is, to the best of my knowledge, not the case from people from Asian ancestries. And so here I believe that we cannot. I do not know, of course, all the literature, but I don't remember a paper. Maybe that some people know it, but where this has been comparing with people from Asian ancestries, comparing 25, 24, 25. But this can be also. I don't have personally experience with this, but this really could be interesting in the future if people have got access to of course volunteers that would agree to do this. That it would be very interesting to measure 25, 24, 25 in Asian.
In my own, we have published some data to kind of show we really could not find the relationship between vitamin D and PTH levels. The same, the 30 nanogram per ml cutoff, which is taken as God's spell in the West. We have not been able to find a correlation between 25D and PTH levels in Asians in a multi-ethnic community such as Singapore. So let me see.
But maybe the ratio could be interesting. Maybe the ratio could be interesting.
Which is not something that we have looked at. And I'm sure. I'm burning with questions actually, but I shouldn't abuse my privilege as chair. So we'll leave it towards the end. Those kind of questions. Is there anything else? I think, Etienne, for now, I think people are still kind of coming in and getting into the flow of things and digesting stuff. So I'm sure we will have lots of questions afterwards. But for now, I think we will stop here with this first presentation. Again, merci beaucoup. Thanks a million really for that wonderful presentation. So I will now invite Dr. Sam Vasikaran to take over. And Sam, you can start sharing your slides, I guess, and we go from there.
Thank you, Manju. Thank you for your kind introduction, and thank you for the opportunity to speak. Let me see. Okay.
Perfect.
So The
Just
topic.
to the slideshow, Sam. Yeah, good, perfect. Okay, I'll mute and I'll go off now.
Thank you again. The topic given to me is the clinical utility of bone turnover markers in the management of osteoporosis, and got a couple of slides also in the setting of renal failure. So the agenda is the introduction to bone turnover markers, followed by clinical use of bone turnover markers in osteoporosis. So touch on cutoffs and therapeutic targets for monitoring therapy, monitoring offset of anti-resorptive drug effect, and as I mentioned, bone turnover markers in osteoporosis in advanced CKD, that's chronic kidney disease. So starting with bone remodeling, in adult skeleton, bone is continuously being remodeled. This is necessary to maintain the strength and integrity of the skeleton. Now, bone remodeling starts with the attachment of osteoclasts to the bone surface, usually where there is a microfracture or some microdamage, followed by activation of the osteoclast, resorbing a cavity. And when the resorption cavity has been completed by osteoclasts, osteoblasts are attracted to the cavity. They start forming osteoid, so they secrete collagen and form osteoid, which is then mineralized to form bone. In adult skeleton, the amount of new bone formed should equal the amount of new bone, amount of bone that's resorbed in order for the bone mass to be maintained. And this is the case in young adults, but at menopause and in old age, the amount of new bone formed may be less than the amount of bone resorbed. And in fact, the amount of bone resorbed may be increased due to the formation of larger number of bone resorption cavities due to activation of osteoclasts, as well as deeper cavities which are not fully covered by the new bone. This can lead to a decrement in bone mass over time, leading to osteopenia and osteoporosis. So the theory of bone turnover markers is based on the fact that they are released during this bone remodeling cycle. Bone formation markers are products of active osteoblasts and are synthesized by osteoblasts and secreted into the cavity. So procollagen N-terminal extension peptide is cleaved off from procollagen when collagen is laid down, and the procollagen peptides are released into blood and they can be measured in blood. Similarly, alkaline phosphatase is an enzyme secreted by osteoblasts, and osteocalcin is a non-collagenous matrix protein, again synthesized by osteoblasts and form part of the osteoid. And the theory is that the amount of these bone markers that are released into blood, where they can be measured, correlates with the rate of bone formation. And by measuring bone markers in blood, you can get an assessment of the bone formation rate. Similarly, bone resorption markers are degradation products of bone collagen, so C-terminal and N-terminal telepeptides of the collagen molecule, which are released during bone resorption into blood and then excreted in urine, so they can be measured in blood or urine to reflect bone resorption. And tartrate-resistant acid phosphatase 5B is an enzyme that's specifically secreted by osteoclast, and it reflects osteoclast numbers. So the attractiveness of bone turnover markers one is relative specificity for bone. So when you measure them in blood, they reflect bone activity. Not all of them are totally specific, and I'll come to that. Some of them have some cross-reactivity with other tissue factors, but they're mostly reasonably specific to bone. They provide complementary information to imaging studies, and measurement is easy and it's non-invasive. Blood sample is easily collected. And there are a variety of assays available. And this can be a benefit, but it can also be a problem. But the fact that a variety of assays are available means that we can look at bone in different ways with different assays and get a full picture. The limitations include the fact that bone turnover markers reflect total skeletal turnover. They don't give you an idea of focal disease. They give you an idea of what's happening throughout the skeleton. Whereas with imaging, you can get an idea of what's happening at a place of interest. And as I mentioned, the specificity to bone metabolism varies between bone turnover markers, and we have chosen markers which are reasonably specific to bone. And many of the markers are affected by renal function because they are excreted in the kidneys, so they accumulate in renal failure, and they can cause an artificial increase in renal failure and therefore can be misleading. Biological variability is mentioned, and day-to-day variability is more of a problem for urine than for blood, but even with markers in blood, variability can be low or high, and I'll touch on that later. And as I mentioned, multiple assays for the same analyte can lead to lack of standardization and different labs producing different results for the same test. So markers of bone resorption especially, but bone turnover markers in general increase at menopause in women. And this diagram from Garner's group shows that NTX starts to increase around 45, around menopause. It reaches its peak and then decreases to some extent, but bone turnover markers remain raised in postmenopausal women at all ages compared to premenopausal women, suggesting that there is increased bone loss in menopause and postmenopause. So as mentioned already, we have designated serum beta CTX and P1NP as the markers, reference markers for bone resorption and bone formation in osteoporosis, and I've highlighted that this is specifically for osteoporosis, not for other bone disease. So standardized collection is important to avoid effects of food and circadian rhythm especially for CTX, because it's affected by both. So we measure CTX and bone markers in general in the morning fasting specimen. And also CTX is more stable in EDTA plasma. So we should probably say plasma CTX rather than serum CTX to be specific. Whereas P1NP is minimally impacted by circadian variation or diet and is stable in serum or plasma. However, if you're measuring both, you would take the sample in the morning in the fasting state. Both P1NP and CTX are available on a number of assay platforms. We have specifically looked at two automated platforms, Roche Diagnostics and IDS-ISIS system. They both measure P1NP and CTX. The CTX assay for both are targeted at the same molecule. However, there is significant variability in the numbers that they produce. So you can't use the result from one method to the other interchangeably, even though they are standardized by the same reference. With regard to P1NP, the Roche assays measure total P1NP, whereas IDS-ICIS measures intact P1NP, and intact P1NP measures intact molecule of P1NP only, whereas the total P1NP assay recognizes the intact P1NP molecule as well as fragments, monomeric fragments, especially accumulate in renal failure, and that can cause problems. However, in patients or subjects with normal renal function, the two assays give similar results. So in fact, they can be used interchangeably in subjects with normal renal function. There are other automated platforms starting to produce these assays. We haven't examined them, so I haven't mentioned them here. The manual assays, which have been around for a long time, are an RIA for P1NP, the Orion diagnostics assay, which was first FDA approved in USA and has been in use for a long time because of that. And then ELISA assays available for CTX, which is produced by IDS. Now, I have given you the reference interval for premenopausal women suggested for the Asia-Pacific region. I have to apologize because I initially thought this was specific to an Asia-Pacific audience. In any case, this is a reference interval that has been put forward by a consensus statement for the Asia-Pacific region. And this is not based on a study performed in Asia-Pacific population. It's based on, it's collating data from a number of published papers. So this needs to be verified in each Asian country. Ideally, each country should have a harmonized reference range for its markers so that patients can move around in their country. Wherever they go, they get the same assay and the same reference interval. Of course, we have a long way to go for that. At least in Australia, we have got harmonized reference intervals for beta CTX and P1NP for adults, males and females, premenopausal and postmenopausal females. And that's used universally within Australia. And as I mentioned, the P1NP reference intervals can be used interchangeably for the Roche and IDS system for normal renal function subjects. The beta CTX assays give different results. This is for the Roche system. So here's a 65-year-old woman with clinical history of query osteoporosis, and this is the set of tests that we offer as a bone profile: calcium phosphate, creatinine, PTH, vitamin D, alkaline phosphatase, and P1NP and CTX. And as you can see, the results are quite all within normal range, so unremarkable. So how do you answer this question? Has this patient got osteoporosis? Well, we can't answer this question by a blood test because biochemistry has no role in diagnosing osteoporosis. That's done by bone density scanning. Of course, if they have a minimal trauma fracture, clinical diagnosis of osteoporosis can be made as well. However, bone turnover markers have no role in diagnosing osteoporosis. And as you can see, the majority of patients with osteoporosis, in fact, have their bone markers within the normal range, although mostly in the upper half of the reference range, but about 25% of them have raised bone turnover markers. I'll come to that later. If the bone turnover markers are markedly raised, then you have to look for and exclude secondary causes of osteoporosis, such as primary hyperparathyroidism or myeloma. And in our country, we look for Paget's disease if especially bone formation marker is increased drastically, or metastatic bone disease. So the initial assessment of a patient with osteoporosis after bone density measurement is for absolute fracture risk assessment, because the treatment is really for fracture risk reduction. So we want to find out what the fracture risk is for the patient, and if the fracture risk is high enough, institute treatment. A combination of risk factors such as low bone density, raised bone turnover marker, prior fracture, and increased age predict fracture more strongly than one risk factor alone. And at any given age, the 10-year probability doubles with the presence of a single risk factor and markedly increases with the presence of more than one risk factor. Despite all this, currently bone turnover markers are not included in absolute risk calculation due to lack of adequate data. So the FRAX calculator is commonly used for fracture risk assessment, and in Australia we have the Garvan risk calculator. Bone turnover markers really haven't been included because there is not enough data to include them. So what are the other roles for bone turnover marker? And that's really in monitoring treatment, for response to treatment, and offset of treatment effect when treatment has been ceased. So here's the same patient after treatment with alendronate, calcium, and vitamin D. And if you can see the changes seen in the biochemistry, calcium has decreased. Phosphate has also decreased. In this patient, renal function has remained the same. PTH has increased. Vitamin D has increased because the patient has been started on vitamin D. The bone markers have decreased. The reason calcium decreases with alendronate and all anti-resorptive treatment is because they stop the osteoclast from bone resorption, resorbing bone, which releases calcium into blood. And there is a gap between the reduction in osteoclastic activity and the osteoblastic activity. And this leads to a reduction in calcium being released into the blood. And this causes the reduction in serum calcium, which leads to secondary hyperparathyroidism. That's why the PTH increases. And that causes or a reduction in phosphate. They don't get hypophosphatemia in most cases. And of course, reduction in bone turnover markers due to reduction in bone turnover. So is this patient responding to treatment? There is, you can see a treatment effect. Is this adequate? So the aim of treatment is to prevent fractures. Treatment efficacy is confirmed by a surrogate marker, either BTM, bone turnover marker, or BMD. BMD takes a long time to change, 18 to 24 months for bisphosphonate, whereas bone turnover markers show response within 1 to 3 months, and therefore they can be used for early assessment after treatment. So this diagram shows changes in CTX following alendronate, which is a slower reduction than with an intravenous bisphosphonate zoledronic acid, but in both cases, there's a significant reduction by 3 months, whereas in IV zoledronic acid within a month. And this is followed by a reduction in bone formation marker because of coupling. So I told you that most subjects with osteoporosis, most patients have bone turnover markers within the reference intervals. So this purple boxes show the lower and upper half of reference interval for premenopausal women, and the majority of osteoporosis patients have bone turnover marker in the upper half of the reference interval, but about 25% have a raised reference interval. And this is a slide that Richard Estelle provided. And post-treatment, most patients normalize their bone turnover markers, and the majority of patients have bone turnover in the lower half of the reference interval or below the median of the reference interval. So what is the target for treatment and what's the significant change? And we have calculated those. For CTX, there should be at least a reduction of 100 nanograms per liter from baseline, and the target is less than 300 nanograms per liter. This is assay dependent. For Roche, it will be slightly lower, and for IDS, it will be slightly higher. With the serum P1NP, we want to see a reduction of at least 10 micrograms per liter to a target below 35 micrograms per liter. And this is the same for Roche or IDS assays. Now, following denosumab therapy, most patients reduce their bone turnover markers well below the normal range. So we don't need to monitor treatment for denosumab therapy. Similarly, with teriparatide, as long as the injection technique is correct, there's a major increase in bone formation marker followed by a smaller increase in bone resorption marker, and a 10 microgram increase is shown to be significant. And in most cases, the increase would be much higher than that. Poor compliance is the main reason for treatment failure, because long-term compliance with no obvious effect is very poor, and it's been shown that compliance at 10 months is about 50% for alendronate, and similar for HRT. And so monitoring, generally monitoring, but with bone turnover markers, if possible, could improve adherence to oral treatment. So measure P1NP or CTX at baseline and 3 months after starting oral bisphosphonate therapy. Check for satisfactory decrease. If the decrease is significant and into the lower half of the premenopausal median, the numbers I've stated, treatment can continue. If there's no decrease, you have to check for adherence to therapy, and if that is the case, then you may have to look for secondary causes for osteoporosis or other factors which are interfering with the treatment, and possibly consider alternative anti-resorptive treatment if the patient is not responding to treatment despite taking the medication. So monitoring offset of treatment is also a utility for bone turnover markers. Now, with bisphosphonates, after 5 years of alendronate or 3 years of zoledronic acid, you may stop medication depending on their bone density and lack of further fracturing. Offset of treatment is slow for bisphosphonates, but it can be monitored with bone turnover markers. There's no good evidence for their ability to show utility in monitoring. However, it's still used in managing offset of treatment, so that when the bone turnover marker increases above the median again, you can reinstitute treatment if that's felt to be appropriate. With cessation of denosumab, on the other hand, there is a rebound increase in bone turnover, and this is possibly associated with vertebral fracture risk increase. And as you can see in this diagram, both CTX and P1NP rebound after 24 months of treatment on cessation, and they don't just go back to baseline, they increase well above baseline. And this has been suggested as a cause for vertebral fractures, which sometimes occur after cessation of denosumab therapy. And therefore, a position statement has been put out by the European Calcified Tissue Society that when denosumab is ceased, bisphosphonate treatment may be instituted, either zoledronic acid or alendronate, and bone turnover markers may be used to monitor the efficacy of the bisphosphonate therapy to offset, to reduce that rebound, causing increased fracture risk. Now, coming on to CKD, just a couple of slides. This is a 70-year-old woman with CKD history, EGFR of 10. PTH is 39, as you can see, the unit sign, picomoles per liter. So that's about 4 to 5 times the upper limit of normal. Total alkaline phosphatase is normal. Total alkaline phosphatase isn't affected by renal failure itself. P1NP and CTX are raised. So the comment we have on these results in renal failure is these CTX and P1NP may be artificially increased in renal failure, and also calculated urine indices may be unreliable in renal failure. In fact, the only test we offer is total alkaline phosphatase. However, KDIGO has recommended that apart from PTH, bone alkaline phosphatase may be used to evaluate bone disease in stage 3 to 5D CKD. Markedly high or low, markedly low values predict underlying bone turnover. There are other bone turnover markers which show promise apart from bone alkaline phosphatase, specifically intact P1NP assay, and especially tartrate-resistant acid phosphatase 5B. They are not affected by renal failure, and they show promise in being good, useful markers in renal failure. Now, in osteoporosis in advanced CKD, this is really CKD 4 and 5 and dialysis patients. There are a number of limitations in treatment and assessment. CKD 1 to 3, the assessment and treatment of osteoporosis is very similar to subjects or patients without renal failure. With advanced CKD, the suggestion is that PTH is not optimal in reflecting bone histomorphometry. So at this stage, the recommendation or the evidence suggests that PTH twice the upper limit of normal or less than twice the upper limit of normal may predict low bone turnover in dialysis patients. And the units depend on what we use, but low bone turnover may be seen with patients with PTH up to 5 times the upper reference limit. Now, this is important because if you want to treat these patients with anti-resorptive therapy, you want to exclude low bone turnover disease. And therefore, we need to be confident they don't have low bone turnover. And without bone histomorphometry, bone biopsy is quite invasive. We need markers to be confident with that. I mean, if PTH is up to 5 times the upper reference limit, they might still have low bone turnover disease. There is some suggestion, and I've given the list of references below. Bone alkaline phosphatase has been found to be useful. So different assays give different numbers, lack of standardization, and also lack of similar units. So 20 micrograms per liter by the Ostase assay, or 30 units per liter by an activity assay, rules out low bone turnover disease in CKD in the absence of vitamin D deficiency or very high total alkaline phosphatase, which can interfere with bone alkaline phosphatase assay. So this is really close to the upper reference limit of bone alkaline phosphatase. However, it's very useful for ruling out low bone turnover disease in CKD before starting treatment with anti-resorptives. Now, I've given you this, shown you this table just to show that for picomoles per liter units that we use in our country, the reference intervals are quite different depending on the assay that you use. This is a bit outdated, so you really have to use the reference interval that have been developed in your laboratory for your assay, and Etienne has discussed this quite extensively. And in some cases, anabolic agent may be used. Now, then they may not be licensed in your country, or they may not be approved for use, but if they are, you need to exclude a high bone turnover before starting anabolic agent, and PTH less than 5 times the upper reference limit may be a useful cutoff to use. And similarly, a bone alkaline phosphatase level of 30 micrograms per liter by the ostease assay, or 40 units per liter by the Quiddle assay, may be helpful in ruling out bone turnover disease in CKD. Whether using both markers together will improve the diagnosis, there's no consistent results from studies. Some show that they do improve performance, but it's not consistent. But both of these have, with some variability, help with making those decisions. Well, with this, I conclude my talk. I just like to acknowledge the IFCCIF Committee on Bone Metabolism, chaired by Etienne Cavalier, Richard Eastel for some of the slides, and Jaja Salam from Sheffield again, who is my go-to person for CKD MBD. Thank you. I'm happy to answer questions. There are some references here if you want to look them up.
Great. Thank you so much again, Sam, for that, again, such a comprehensive kind of presentation. Not easy topics that I gave both of you. I apologize for it. And regarding the Asia Pacific audience, yeah, I swear, I really thought that, at the most we'll have about 25 to 50 people from Singapore maybe attending. Never in my wildest dreams that I think that there's going to be attendees from all over the world, So, but, there are several questions, Sam, which have been raised, but in the interest of time, because we're running just a little, behind, just a teeny weeny bit, I'll just maybe pick a couple of the questions, and then maybe at the end we'll probably come back to them, and or maybe we can answer them, type the answers in.
Yeah, my apologies for taking more time.
No. You were just on time. That's fine. I mean, so okay. So a couple of questions. Let me pick a couple. So one anonymous attendee has asked, when do you use urine NTX instead of CTX? So I presume he's talking about, urine versus serum markers of bone turnover or bone resorption.
Yeah, the only time I would use urine NTX instead of serum CTX is if you don't have the CTX assay available. I mean, if you only have the platform, the ortho-diagnostic platform for NTX, and you don't have either any of the CTX platforms, then it's just, in my opinion, and I'm sure Etienne will say the same, it's second best. And being a urine marker, there are additional problems with variability.
Exactly. Yeah, the variability is so remarkable. Then I guess, this is more kind of a very practical kind of question. And somebody has asked, the hospital lab I work measures only cross labs. And I guess the person is getting a little confused between the brand name, the Cross Labs and CTX.
It is CTX.
Yeah, so it's just
And
the Alexis assay, right? The name of the Alexis assay is called Cross Labs, correct?
So in fact, if you have one marker, you don't need to measure CTX and P1 and P for anti-resorptive therapy. For anabolic agent, ideally P1 and P, whereas for CTX you can use for anti-resorptive therapy, you can either use P1 and P or CTX, whichever is available.
Yeah, and it's the brand name, the name of the assay that is it's called Cross Labs. Yeah, and then there was another question. So you talked about actually the decrease that you expect to see following institution of an anti-resorptive agent. Who's this? Penny has this question of if alendronate is given and P1NP reduces by more than 10 micrograms per ml, but remains above 35 micrograms per liter. I'm sorry, is that a concern? So I guess, is it the rate of fall, or is the decrement that is important, or the absolute number that it finally reaches?
Yeah, ideally both. Some patients start off below 35, in which case you really want to look at 10. If it remains much higher than 35, I mean, if it's just over 35, I wouldn't worry too much. But if it's a lot higher than 35, and if you do actually see a decrease, it might mean that the patient is taking half the dose or not regularly. Alternatively, you need to look for secondary causes, which might be increasing bone resorption, and they may not respond optimally to bisphosphonates, such as if the patient's got. So you need to look for secondary causes. We can think about it later.
Okay, I mean, there's several questions. I don't know how many I can go through in this very short time, but somebody has brought up, I'm so sorry. Somebody has brought up the question of bone turnover markers with romosozumab, which a lot of you might know that romosozumab is a sclerostin antibody inhibitor. So any data on bone turnover markers in the with use of romosozumab?
Yeah, so it's got dual action. And the research study has shown that there is a transient increase in P1 and P. It peaks about 1 month and rates increase for about 3 months and then gets back to normal. Whereas there is a sustained reduction in CTX over time. So it's the ideal dual action agent, but because it's given parenterally, monitoring is probably not needed because we're not worried about compliance as long as you know the patient's coming regularly for the injection.
Okay, yeah. And maybe I'll just do one more question. There are like about 5 or 6 more questions, and I do have a lot of questions, but let me just see. So there was this, 1 second, so somebody did ask about, I mean, you did mention the fact, about compliance probably. So are there any factors? So this person has asked, are there any factors which may give a falsely suppressed CTX? 89-year-old female with osteoporosis on tail end of teriparatide. I'm not sure what exactly he means by that. With a P1NP of 38, the reference being 15 to 115, and CTX of less than 0.07, the reference range at their lab being 0.1 to 1. Renal function is okay. So essentially, I guess, I mean, he's talking about CT. I mean, with teriparatide, I presume you would expect to see an increase in both P1NP as well as CTX, because I mean, because of the coupled kind of coupling between the bone formation marker and the bone resorption marker. So he's saying, P1NP is 38 and CTX is less than 0.07 with teriparatide.
Yeah, so 0.07 is at 70. 70. So that's at the lower end. Which it is surprising. There is a discrepancy there. one of the issues is analytical interference, and that's something you need to, I mean, this is another area where you may want to do an alternative bone resorption marker, especially if the patient is going on anti-resorptive therapy, either by an alternative assay, if you do it on IDS or Roche, or an alternative resorption marker such as NTX. I don't think many people have daughter-resistant acid phosphatase yet, but yeah.
Yeah, I was thinking, I mean, as an answer, a couple of questions, a couple of things that came into my mind with that question is that possibly, I mean, was it measured fasting? Because food, obviously intake of food can cause a decrease in CTX, right? So maybe it was not done fasting. That's one of the things. And again, compliance issues, right? Because again, the P1NP, which this doctor mentioned, it's only 38. I mean, so the reference being 15 to 115. So possibly the fact that maybe the person is not taking teriparatide, because you would expect an increase in both P1NP as well as CTX, right? So those were the things.
And 38, I missed the part that he was on teriparatide. It's unusually low for teriparatide.
Exactly. So I think maybe compliance should probably be also a question. Yeah.
CTX is very unstable. So if so we do say ideally collected into EDTA plasma, it does degrade very quickly otherwise. So, whereas P1NP is very stable. So that's something that needs to be considered.
Okay. Folks, we really need to move on, and we'll see whether we can answer all the other questions at the very end. So I think, Sam, we'll close this particular presentation, and I will invite Etienne back on stage, on the virtual stage, to talk about, oh my goodness, Etienne, I'm so sorry for having given you this topic, but estimation and measurement of GFR, all the controversies that exist amongst us. So please, Etienne, if you could share your slides.
Yes, so I hope that you can see my slide, Manju. Is it okay for you? Yeah, I believe it's okay. Okay, thank you very much. Yes, this was a big title, and thank you for following me back on this talk about the estimation measurement of GFR. Of course, I would like to start with creatinine, which is an important, very small molecule, as you can see the chemical formula here. And creatinine has been described by Mr. Jaffe in 1886. So this is not this century, not the century back, and there was 2 centuries before. And Mr. Jaffe has described it that this coloration of red when you put picrate and alkaline, and this creatinine gives you this color, and this was back in times. And you know that most of laboratories worldwide are still using the Jaffe method to either compensate it or not whatsoever calculation are behind, but to measure creatinine. But if you look back in time, in 1939, the first publication of enzymatic methods for analysis of creatinine. And you can see that already 90 years ago, those authors said that we should abandon the Jaffe method because of all the interferences that can happen with the Jaffe method, interference by sugars, interference by proteins, by bilirubin, and so on. So 90 years ago, it was considered that we should stop using Jaffe, that they call the picrate alkaline methods, and switch to enzymatic method. But unfortunately, this is not the case in most of laboratories worldwide. So, you know, having creatinine is important, but clinicians prefer to have an estimation of GFR, and this estimation can be achieved through formulas. And of course, the first formula I want to present today, that was not the first formula to be published. It was published in 1936 by Dr. Cockcroft and Dr. Gold, and just to mention, this is important, this formula does not estimate GFR. This formula estimates creatine clearance, which is different because that creatine can be secreted in the tubules by the tubules. So creatinine is not a perfect marker of GFR. So Cockcroft does not estimate GFR. Cockcroft estimates creatine clearance. Going back to this publication, very interesting. All of you know this formula, which takes the weight into consideration. But for us in laboratories, we don't have the weight of the patients. We have access to the age, the serum creatinine, and of course the sex of the patient, but we don't have access to the weight. So we cannot provide a Cockcroft formula, gold formula, creatine clearance results without the weight. But just to give you, have a look at the paper. So they recruited 538 consecutive patients in the Veterans Hospital. So most of them were males. So 96% were males because of this hospital. But it's very fascinating to find that among those 534 patients, they only kept 236 patients because half of them had two large discrepancies between the 24 hours collection urine, which really shows that having a good collection of 24-hour urine is very complicated, and that was the reason why they had to abandon most of those patients. So they published the method on 236 patients, which is, of course, today, if you want to do it, of course, you will be rejected by even the smaller journal without no impact factors. So that was a big issue. And again, they came to have a factor of females of 0.85. But when you see that it's that among those women, there was only 4% women. So this factor has been established on less than 10 women, which gives you an idea of the precision of this formula. Then in 1999, there was this what we called the CKD EPI Consortium. We published the first MDRD formula to estimate GFR. And this formula, this MDRD, really estimate glomerular filtration rate because this formula uses iothalamate clearance as a reference. And this is really a true measurement. Of course, this MDRD formula included much more patients than the Cockcroft. They use the kinetic alkaline peak rate assay that I just mentioned. It was not the best. And you can see there was a factor here that was provided. And also for the first time appeared correction factor, of course, if the patient was black, as mentioned here in the paper. Of course, they use also urea, nitrogen, albumin, and sex for calculation. And this was published as a method. Later on, the authors published a simplified equation. It was not published in the paper, but just an abstract published in JASN in 2000. You can see that the factor has changed as well as the factor that they use for correction factor for black people. And this simplified method took only consideration age, creatinine, female. Of course, all things that we have besides the race of the patient, we have access to all of this in our laboratory, so we can provide this estimation of GFR in any patient once we've got all those. So in parallel with serum creatine concentration, we could provide estimation of GFR. Well, a big issue with this was that this paper shown by the same team saw that there was a big issue with standardization of creatine. Nobody take care about creatine standardization in the past, but when you look at the result they observed between two different methods, which was the use at the Cleveland Clinic and the NHANES method laboratories, they use a Cleveland Clinic measurement, Hitachi and Roche, and there was a difference of 0.23 milligram per deciliter between the Cleveland Clinic and the NHANES, between the Beckman and the Hitachi. And this was because of a lack of standardization again, and the true impact of that is that taking a concentration of in a 60 years old white man of having a 1 milligram per deciliter creatinine, the eGFR was 110 if it was measured with Roche, and 181, sorry, if it was measured with Hitachi. So a huge discrepancies above more than 40 milliliters per minute just because of creatinine standardization. Of course, this was not at all acceptable, and there was a big effort that has been put to standardize finally creatinine measurement, and with NIST and with IDMS, or isotope dilution method, to standardize kits. So the CKD, the EP teams re-standardized the MDRD formula with, again, another factor, and but it was here the same coefficient for the Black people. But this formula had to be applied for standardization, for standardized creatinine. So later on, in 2009, the same team came with another interesting equation, which is known as the CKD-EP formula, published in 2009. And this formula was interesting because it was divided according to the serum creatine concentration, and it could give also a result above 60 milliliters per minute. You can see that in the original publication, there were black, white, or other. Who is other? I don't know. And you had to apply this equation, taking into consideration, again, serum creatine, age, and the sex, and the racial factor. So let's focus a bit about this race factor. Well, this race factor, actually, we with my friend and colleague Pierre Delaney, and also good colleagues from Democratic Republic of Congo and Côte d'Ivoire, and Professor Hans Pottel, we also compare this racial factor. Could it be applied? This, I would call this Black American, African American factor, could it be applied to African people living in Africa, or could it be applied to African people living in Europe? And the answer is no, not at all. This factor should not be used, and really insisted on that. So this factor would overestimate the true GFR of people living in Africa and African people living in Europe. So the CKD-EP in Europe, at least, and in Africa, should not be used with this ethnic Black American, they call it Black, but Black American or African American factor, was only for the United States. Of course, you know, after all these post-George Floyd things and very sad things, so the American Society of Nephrology and the American Association of Clinical Chemistry have decided to remove this racial factor, to remove the race from medicine. And so they came in 2021 with a new equation based on creatine and cystatin C. This new equation would not use this racial factor anymore. The problem is that, well, this is the first time that the formula was less precise. You know, the CKD-EP was more precise than MDRD, but for once, it happens that this formula was not scientifically designed, but politically designed. So that this equation does not perform well in blacks, does not perform well in whites, but performs as good or bad in blacks as in whites. So, well, sorry, there is no advantage of one over the other. But for the first time in science, you know, in science, you've got the hypothesis, the thesis, and the demonstration, and the fact here. Before the publication, we knew that this equation, we knew already the results. So, but of course, this was the way that the United States had decided to remove the racial factor, but by providing a less precise equation. Well, we, as the European Federation of Laboratory Medicine and the European Renal Association, well, we do not really agree with this position, because this equation would be less precise in our European patients and also in African patients. And again, since we were not using in Europe and in Africa, or we are not supposed to use this Black American factor, we did not have any issues with race problem, because there was no use in Europe of this factor that was not applicable to Africans living in Europe and with African population. So we stated, we position ourselves saying that we should not use this new equation published by in the United States in 2021, but either remain with the CKD-EP equation without the race factor, which was not applicable to our population, or we should use another equation that I will show you later on, which is the EKFC equation. The problem is, what about Asians? I mean, you've seen this paper where nobody's taking care of paying any attention to Asian people, which represent more than half of the PKU population in the world. And again, what's in the name? What does Asian mean? I mean, Asian can so much diversity in such a big part of the planet. So what does it really mean? And I would just like to mention this clinical case of an Asian 65, well, again, between Asian 65 years old lady. She's weighing 70 kilograms. And what will be her estimation of GFR if her creatinine is 1, 1.5, 2 or 2.5 milligram per deciliter? I believe that most of the practitioners of that dealing with Asian people could raise this question, which is quite important. And when you look at the different equations that have been, or adaptation of equation, that there are few papers, very few papers that really took this problem into consideration. And there is a Chinese group that have proposed an adaptation of the CKD-EPI equation, but for adapted to Chinese population. There was the same approach with Korean population, and also a modification of the CKD-EPI equation for Japanese population. And all those equations have used different ethnical factors to adapt to their own population. But here is what this gives to answer my question. So this is the creatinine, if this lady had the creatinine of 1 milligram per deciliter with the Chinese equation, Japanese equation, Korean equation, CKD-EPI 2009 equation, Cockcroft and Gold equation, and the race-free equation. And you can see that according to the equation, you can have very different response. Which, for instance, according if you use the Japanese equation, your GFR here will be far below 60, where for the others it will be above 60. And you can see that it's the case with all those equations. The Japanese equation giving much lower values. The race-free was not better, and you can even have, for instance, with this creatinine, this large discrepancy. So it's a mess, really, with all those equations that had issues in their design, using probably a non-standardized creatinine assay, and maybe some question raised about the reference method that was used to establish those equations. So a solution for these issues that we see in Asian people, and maybe also in other parts of the world, might be, or at least I believe, that is the EKFC equation, which stands for European Kidney Formula Consortium equation, that has been published in 2021. The main author being Professor Hans Pottel and Pierre Delaney, for leader author for this equation. The big advantages of this equation over the others is that in this equation, you normalize the serum creatinine of your patient by the median serum creatinine concentration of your population, meaning that each lab has, of course, thousands of results of patients and of people, and so the median of this lab really reflects the own population. So the median can be different in Tokyo, can be different in Seoul, can be different in Brussels, can be different in Africa or in Australia whatsoever. So you really standardize, you normalize the creatinine of your patient by the median of your own population. So this equation is really adapted to each situation. And another big advantage of this equation over the others is that it's totally available from 2 years old to the older old. So it's been totally validated from very young kids to the older people with a single equation. And it takes also into consideration the physiological aging of the kidney after 40 years old. And I was very happy to see this publication published by a Korean team in Annals of Laboratory Medicine this year in 2023, where the authors analyzed more than 1,500 Korean patients, and they compared with a reference method here, which was DTA clearance. They show that using there was the EKFC formula, which was the best to estimate the GFR of the current population, and these authors, they even used the 0.7 or 0.9 for women and men. I'm pretty sure that if they had used the median of the Korean population, it would have been even better over classing the other equation. But of course, this study has been achieved. I don't know when, maybe in Seoul or on the Korean city. I'm not familiar with the Korean population. I'm not familiar with the diversity of the different ethnicities you can find in Korea. But I've been once in Singapore, and well, I've been really surprised to see how diverse the population was in Singapore, and the problem is that, of course, in big cities just like big cities in Brussels or whatsoever cities in the United States, you will have lots of discrepancies. And of course, if you make the median of your local population, this can be a median of the result would be the dominant population. So this is a big limitation of cystatin of creatinine. So now I would like to say a few words about cystatin C, which is a small peptide produced by all the cells of our bodies, which is filtered by the glomerulus, reabsorbed, catabolized by the tubules. And half-life is good. The values are quite similar in men and women, whatever the technical background. And cystatin C is really a real gender and race-free. And important here, compared to creatine, it's also a gender-free parameter. And because it's less and much less influenced by age, gender, and ethnical background of the subject. And we had the chance to have our paper published here in January 26, 2003 in the New England Journal of Medicine, where we had the chance to publish the EKFC equation for cystatin C, which is really an equation that is totally race-free, gender-free, and can be applied from the younger to the older people. And I think this is very important to really mention that, because race is a thing, but we have also transgender patients, and well, it is difficult to really know which creatinine reference range you should use, but cystatin C is totally gender-free. At least the equation that we propose is totally gender-free. Well, it's not perfect, of course. There are some issues with cystatin C. It's more expensive than creatinine. It's not available everywhere. I'm not saying it's available in Singapore, but I'm pretty sure that the United States, I've got the feeling that they will more and more use cystatin C, which if there are more labs using cystatin C, there will be an important impact on the cost. Just pay attention that all those equations are interesting at the population levels, but may present many issues at the individual levels. And you are all doctors, and you are not treating populations, you are treating the patient which is in front of you. And no equation is magic. So there is no, if there is an issue with if for instance, if the patient has is an amputee for a couple of members, the creatinine or cystatin C will be bad, and the equation will not correct this. So no equation is magic. So even if you have here a bias of 0 with your equation compared to the measurement of GFR, don't look at the precision of those equations. If you got this patient in front of you, the estimation of the GFR will be 60 milliliters per minute, but this patient will have a GFR of 42, and this one, other patient with having the same estimation of GFR will have an estimation, a true measurement of 78. So these equations are not magic, and always consider the patient that you have in front of you. This is just an estimation, and when you look at this, the lack of the precision of those methods, even if the bias is 0, this can have an impact. So there are many situations where estimation GFR is not enough. There are situations where you would like to measure this GFR, and this paper is published by the people from the CKD EPIC consortium, and these are the conditions where you would like to really measure GFR and not estimate it with an equation. And what can we do to measure GFR? Well, there are different markers that can be used. I know in iotelamate, IOXOL, EDTA, DTPA, but at the end of the day, the only which is worldwide available is IOXOL. Inulin is not available anymore. Iotelamate is used in the United States, but it's more isotopic. EDTA is difficult to have for the moment, and EDTPA is not a good method to measure GFR. So IOXOL clearance can be achieved in all countries in the world. This is really something I would like to promote. It's very easy. It's an extension of 5 meters of OmniPack solution. OmniPack is something that is used by radiology daily in radiology. We only inject 5 mL we take blood samplings at different times, and we measured ioxol by HPLC UV or thermal mass spec, and we really see the decrease of ioxol. And according to this decrease, you can really measure the GFR of the patient. When you read the literature, people say that it's cumbersome. I don't agree with this. It's just like an OGTT test. Of course, the patient has to stay a few hours for at least 300 minutes. But at the end of the day, I mean, it's to have access to a real reference measurement and not just an estimation. It's robust. There are external controls. You only need a basic HPLC, and this, I would really like that this measurement can be available in every country in the world, and even in emerging countries, this is something that can be done. Price is not so much expensive. I would like get too much in detail, but this is really something that could be done. So if I come to my conclusions, and I would be happy to share this discussion with you. When you look at the literature, what so-called Asians have been forgotten in most of the big studies aiming and providing equation to estimate GFR. I'm pretty convinced that the AKFC equation is really something very promising because of this normalization by the local median creatinine or cystatin C. The AKFC cystatin C equation is much more both gender and race independent, and this really could be envisaged in big cities, big cosmopolitan cities, or in countries where you've got lots of ethnicities that are present. I think that cystatin C is really something that could be promising. And please do not forget the eGFR remains an estimation. And in many clinical cases, you do not want to estimate the GFR, but measure it, for instance, bioxol clearance. And I would really like to work that for that each city or country should have at least one lab that could be able to measure GFR. And again, thank you for your attention, and I will be happy to answer your question.
Okay, Etienne. Okay, another tour de force. You outdo yourself each time. Etienne, again, lots of questions, but I think most of them are again pertaining to what you and I have been talking about for the last several months. The whole issue of, given the fact that obviously the iohexol and cystatin and all that are not yet routinely available in most countries, and pertaining back to our discussion today, which is all centered around metabolic bone diseases and osteoporosis, there are a couple of questions on what would you choose, given the current limitations on availability of these other methods of calculating eGFR and estimating eGFR. Say, for instance, if you were to to decide to start on a bisphosphonate, which would you use? Would you use CKD EPI or creatinine clearance using Cockcroft and Gold?
Well, I would never. Well, I would not use Cockcroft and Gold and creatinine clearance. I mean, that's clear that it is not recommended It's not recommended by any society, scientific society in the world, to use Cockcroft and Gold or creatinine clearance to estimate the GFR. The only advantage of Cockcroft and Gold is that it takes weight into consideration. And in very old person, here I'm talking about the old patients, maybe that the weight of the patient is more a reflection of the good health, well, the relative good health of the patients, better reflecting that than the creatinine clearance. But besides this, and geriatricians sometimes prefer to use the Cockcroft and Gold or the creatinine clearance or the estimation of the creatinine clearance because this since it overestimates the true GFR, they say, well, we prefer to be on the safe side and overestimate GFR, but even if we take that into consideration. But I would never use this equation for any other purpose, and I'm even not sure that it's a good approach by geriatricians.
Okay. What about now? Oh, wait, I'm sorry, go ahead.
No, but to go on with your question, which equation should I use?
The CKD.
Well, the CK, well, basically you've got three equations: the CKD-AP 2009, the new formula in 2021, and the EKFC formula that could be used. Of course, in Sweden they're also using a very interesting Lund-Malmö equation, but this is more validated for Swedish people. But it's a very good equation. But you've got in front of you three equations. You've got variants of the CKD-AP equation that have been published with different ethnical factors in China, Japan, Korea. You see that it's a mess. I already showed that it's a mess.
Exactly.
I mean, the ethnical factors that have been applied for the Chinese population is even higher than the one which is applied for a Black American population. I mean, this is not really the median Chinese person is quite different than median Black American person. So I'm not sure that this should be used. The Japanese is quite strange because in underestimate. So basically, I think that the paper published by this Korea team in 2023 is really important for me because they really showed for the first time in Asian population that using the EKFC formula is the best one to be used in Asian people, at least in Korean people. So I really encourage researchers and clinical people to see how they can implement, which is the same. I mean, if you can implement the CKD-AP, you can implement an EKFC. It's exactly the same. It's just mathematical software programming, and that's not more complicated. So I would not, at least, I think that it's too early to recommend the race-free equation. I'm not sure that is correct. At least it has been validated in Asian people, and even if it is in Asian people living in the United States, which might be different than Asian people living in Asia again. Yeah. So I think that I would prefer, as we've shown, that the CKD-AP should not be the technical factor of the CKD-AP 2009 should not be used in African people and in African European people. I don't see why there should be also any correcting factor for Asian. Yeah. But I would, of course, I would promote the EKFC equation because I'm pretty sure because this is really linked to the local database of your lab, of your country, of your city, and this is really important.
And just a very practical, what are you using in your center at the University of Liège? What are the clinicians using? Have they already adopted the EKFC?
Yes.
They have.
Yes.
Okay.
Yeah.
Okay.
Yeah.
Okay.
Yeah.
Okay.
They have adapted. So,
okay.
Yeah.
And I mean, and then there was another question about like in obese and underweight patients. How do you calculate PGFR?
Yeah. This is exactly the one of my last sentence. In obese and very underweight patients, you will never have a good estimation of GFR. That's the problem. You have to consider. You have to live with this as long as you don't measure it. I mean, and again, I'm doing quite a lot of aerosol clearance. I'm sometimes very surprised by the discrepancies that you can observe between the estimation and the measurement. So when in clinical situations where you've got a doubt on your creatinine, or if because of the patient is anorectic or the patient is very obese, well, the formula will not correct that, and the estimation will not be good, and that's the reason why it's recommended in population where you will have to at least to measure it, to send it up. But this you can do also with 1 point. But in clinical situation, if just imagine that the patient is totally how do you say that in English? When cannot move anymore, just the head. I'm sorry for my poor English.
No.
Yeah, totally completely immobilized. I mean, if he has no muscle mass anymore, I mean, what can you do? I mean, which creatinine are you measuring? I mean, this will never reflect the kidney function. That's an issue. That's the issue of every cystatin C will be less impacted, but creatinine will be very bad. And cystatin C can be also proposed. But I mean, there is no magic formula for anorectic or for obese patients. I mean,
Okay. Yeah, I mean, I think we could sit and talk about this till the cows come home, and still, I think, we will not, have a consensus or a clear answer. Very, very difficult topic, but thank you for handling it with so much eloquence and grace. So,
thank you.
Yeah. So I think, Etienne, we will move on to the last presentation. The last actual talk of today, which is Sam Vasikaran, who's going to be coming back and talking about bone minerals in the urine, urinary calcium and phosphate measurements, and calculated indices in the clinical management of metabolic bone diseases. So Sam, back to you.
Thank you again. And this talk is titled Bone Minerals in Urine. And the agenda is to discuss urine calcium measurements and look at 24-hour and spot urine calcium and calculated indices, and urine phosphate measurement for the last bit, calculated indices of urine phosphate with a few illustrative cases. So the first one is a fairly straightforward case of a 57-year-old male with hypercalcemia, mild hypercalcemia. PTH is upper end of normal. Sodium, the electrolytes are all unremarkable, eGFR of 69. So generally, we would say this is PTH-dependent hypercalcemia, probable diagnosis of primary hyperparathyroidism. However, you need to consider familial hypocalciuric hypercalcemia, and I'll refer to it as FHH. So FHH is a benign cause of hypercalcemia. It's inherited, so it's lifelong mild to moderate hypercalcemia. They don't develop hypercalcemia later in life, like in hyperparathyroidism. The PTH is inappropriately normal in most cases, but maybe slightly raised, usually up to twice the upper limit of normal for the PTH assay. The main point here is that it's benign, it doesn't need treatment, and parathyroidectomy is not even curative of hypercalcemia. So the population prevalence is really not known, suggested to be between 1 in 10,000 and 1 in 100,000, but maybe higher. We may not have detected all the cases. And the clinical implication is that about 10% of cases of unsuccessful parathyroidectomy can be attributed to FHH. That's these are misdiagnosed cases of FHH, which are unnecessarily operated on. And Christensen and his group in their series, they say they found 23% of their unsuccessful parathyroidectomy cases were in fact due to FHH. So for FHH, really urine calcium studies are very useful for differentiating it from primary hyperparathyroidism. However, we need to be clear that the patient is not vitamin D deficient or on treatment that can reduce serum and urine or serum calcium or urine calcium, as in the case of thiazide diuretic, and therefore can mislead the diagnosis. So urine calcium studies, I'll first mention 24-hour urine calcium. We operate, and most laboratories do offer 24-hour urine calcium measurement, and it's certainly used for investigation of patients with renal calculi to see if they are excreting, if they got hypercalciuria. 24-hour urine collection is problematic, or potentially problematic, because the timing has to be correct. It has to be a complete collection for it to be, or complete and accurate 24-hour collection for it to give the right answer. And we got an adult reference interval of 2.5 to 7.5 millimoles per day. How useful is it to differentiate primary hyperparathyroidism from FHH? There is a big overlap between the two conditions. If 24-hour urine calcium is above the upper limit of normal, then it's probably likely to be primary hyperparathyroidism. However, if it's within the normal range, less than 0.60, FHH is possible, but primary hyperparathyroidism is also possible. So it's really not by itself very discriminatory between the two conditions. So, so the next test that we offer is a spot urine calcium creatinine ratio. So this is a spot urine that's collected in the morning in the fasting state. And often when we do the fasting bone study with calcium, PTH, and bone markers, if required, we do the urine, a spot urine, to make sure that the patient is off calcium. Even if they take it the previous night, it can affect urine calcium excretion. And we usually suggest the second void urine in the morning, because the first void urine may have collected overnight in the bladder and can be affected by the diet, previous night diet. And we correct it for urine creatinine to adjust for dilution of urine or for the hydration status. So fasting spot urine calcium millimoles per liter, we divide it by spot urine creatinine by millimoles per liter, so there's no units. And the reference intervals are 0.04 to 0.45 for males and 0.10 to 0.58 for females. It's one of the few tests where the female reference interval is increased, higher than the male reference interval. And why is that? And that's really because the urine creatinine is higher in males than in females. The urine calcium itself is in fact similar. And I'll show you some slides as to why. And serum creatinine is known to be affected by muscle mass, and urine creatinine is likely to be influenced by this too. So here's an unpublished study we did in our laboratory, frequency distribution of urine calcium in males and females, very similar, almost identical. When you look at the frequency distribution of urine creatinine, males excrete more creatinine than females. That's because they got a higher muscle mass, and really creatinine comes from muscle. So when you calculate the calcium creatinine ratio, obviously the females have a higher level than males. That's okay as long as we know the appropriate reference interval. However, in extremes of muscle mass, this can cause an artifact. So he's a 53-year-old male with muscular dystrophy. Normal serum calcium and urea creatinine is very low, and that's due to low muscle mass in this patient with muscular dystrophy. And when you look at the urine, spot urine creatinine, it's very low. Normally, we would say this is a very dilute urine, and therefore recollect, make sure the patient doesn't drink too much water. But in this case, in fact, this is because the muscle mass is low and the patient is excreting very low amounts of creatinine. And the calcium creatinine ratio seems raised. And that's an artifact of the very low creatinine. So calcium creatinine ratio can be affected by a very low muscle mass or in a very high muscle mass, as in bodybuilders. So is this patient losing calcium in urine? Probably not. And that's shown by the calcium excretion in this patient, which is within the normal range. So what's calcium excretion? That spot urine calcium excretion is calcium creatinine ratio corrected for serum creatinine. So by correcting it for serum creatinine, we take out the muscle mass artifact. Alternatively, you can call it urine calcium excretion corrected for glomerular filtration, and the units are micromoles per liter glomerular filtrate. There is no set normal range for calcium excretion. It's in fact dependent on the serum calcium or plasma calcium. As you can see in this graph, there is an exponential correlation between plasma calcium and urine calcium excretion. So we report calcium excretion reference interval based on the plasma calcium. So the solid line is the mean, and the dotted lines are the two ends of the reference interval for that particular plasma calcium. If there is renal calcium conservation, when kidneys conserve calcium, as in primary hyperparathyroidism or FHH, the urine calcium excretion is to the right of the graph, and in renal calcium wasting, it's to the left of the graph, such as in renal tubular acidosis, where there is calcium wasting. So this is diagram to show the difference in calcium excretion between primary hyperparathyroidism on the left and FHH on the right. And the plasma calcium is higher in this case than in primary hyperparathyroidism than in FHH, but the urine calcium excretion is a lot lower in FHH. So here is a patient with mild hypercalcemia and mildly raised PTH. The calcium creatinine ratio is normal, but the calcium excretion is low. Calcium creatinine ratio is normal, but calcium excretion is low. So in this setting of PTH-dependent hypercalcemia, in a patient with mild hypercalcemia and the PTH is slightly raised, calcium excretion can help to differentiate between FHH and primary hyperparathyroidism. This paper by Gunn and a colleague published in Annals of Clinical Biochemistry in 2004 looked at the difference in calcium excretion in the two conditions and looked at different cutoffs. So at a cutoff of 6, less than 6, almost all patients with primary hyperparathyroidism are excluded. But it is only 15% sensitive for FHH. Whereas less than 14 is a good cutoff with specificity for 95% to exclude primary hyperparathyroidism. Increasing the cutoff to 30, you can increase the sensitivity for diagnosing FHH. So one suggested algorithm is if the PTH is raised or upper reference interval in mild hypercalcemia, measure calcium excretion. If calcium excretion is below 30, you can capture almost all the FHH patients, but that would also capture some primary hyperparathyroidism patients. So if you see, it's only 70% specific for excluding primary hyperparathyroidism patients. And however, further studies can then clarify whether FHH is present, and I'll come to that in a minute. So the next test, and this is what's generally recommended, is calcium to creatinine clearance ratio. That's usually done in 24-hour calcium urine collection. That's because the validation has been done in 24-hour urine collection in the studies. So it's 24-hour urine calcium divided by 24-hour urine creatinine and multiplied by serum creatinine divided by serum total calcium. And in FHH, it's usually less than 0.01. And as I mentioned before, you have to make sure the patient is not on thiazide diuretics or vitamin D deficient, which can decrease calcium excretion, and it can misclassify primary hyperparathyroidism as FHH if that is the case. Christensen and his group looked at 24-hour urine calcium creatinine clearance ratio, and they looked at primary hyperparathyroidism in the top panel and FHH in the bottom panel, and 24-hour calcium creatinine clearance ratio. on the x-axis. And as you can see, calcium creatinine clearance ratio of 0.02 or less captures almost all patients of FHH. So that's nearly 100%. There's 1 or 2 cases that would be missed. However, that would capture quite a significant proportion of primary hyperparathyroidism. So if you want good sensitivity, you would use 0.02. So a cutoff of 0.01 will identify 65% of FHH patients and misclassify only 4% of primary hyperparathyroidism patients as FHH. So if the patient has a calcium creatinine clearance ratio of less than 1, then you can be nearly certain that the patient has got FHH. Whereas if you want 100% sensitivity, you would use 0.02, and you really want to have a good sensitivity. So based on that, you would want to use 0.02 as a cutoff, and further test those patients with genetic testing for calcium sensing receptor mutations. Most of these patients with FHH have mutation in the calcium sensing receptor. There are a couple of other mutations which can also cause FHH. So the recommended test for FHH is calcium creatinine clearance ratio. Moving on to urine phosphate. It's usually used for confirming renal phosphate wasting in the setting of hypophosphatemia. So urine phosphate studies, 24-hour collection. We got a reference interval roughly between 10 and 30 millimoles per day, depending on the laboratory. Fractional excretion of phosphate it can be done on a timed collection or 24-hour urine, and the calculation is given there. But then you provide a percentage. So fractional excretion of phosphate of less than 5% indicates phosphate wasting. The test that we offer, which is probably the most popular for renal handling of phosphate, is TMP-GFR, or tubular maximum reabsorption of phosphate to GFR. And this is a measure of renal phosphate threshold. So the lower limit of serum phosphate below which all filtered phosphate would be reabsorbed. And it's calculated from fasting spot phosphate and creatinine and serum phosphate and creatinine. The equation is difficult. I've given here the equation. It's available on a number of publications, and I won't bore you with the actual equation. But again, it takes into account urine and plasma phosphate and creatinine and comes out with the TMP-GFR, which is really a measure of the tubular maximum or renal threshold for phosphate. So renal threshold for phosphate is increased in renal phosphate retention, whereas it's decreased in renal phosphate wasting, which is what PTH causes. Normal range is 0.75 to 1.35, which is very similar to the serum phosphate reference interval. So here is a patient with X-linked hypophosphatemia. This is a known case in his 50s. The salient features are a very low serum phosphate, slightly raised PTH, and a very low renal phosphate threshold, which is measured as TMP-GFR. So we offer this as a routine test as part of the calcium phosphate panel, and it's very useful for looking at renal phosphate handling. Patients with tumor-induced osteomalacia or any case of phosphate wasting, TMP-GFR gives you a good idea of where the phosphate is going from, whether it's renal tubular loss. And then you can go on to measure FGF23 if that's necessary. So in keeping with the history of X-linked hyperphosphatemia. So one more case. This is a 50-year-old patient with, again, mild hypercalcemia, moderately raised PTH. When we look at the phosphate, it's very low. And we know that PTH causes phosphate wasting. And if this patient has primary hyperparathyroidism, then you would expect renal phosphate wasting. And this is unusually low. We usually see phosphate wasting in primary hyperparathyroidism to a varying degree. So in the setting of hypercalcemia and inappropriate PTH, TMP-GFR can also help to differentiate between FHH and primary hyperparathyroidism. So TMP-GFR greater than 92 has a 95% specificity for excluding primary hyperparathyroidism, and TMP-GFR less than 0.65 has a 95% sensitivity for diagnosing FHH. Ultimately, you would go on to do genetic testing for FHH if these tests suggest FHH based on all the biochemistry. I'll finish with that and happy to take questions.
Okay, Sam, quite a difficult topic. There was so many kind of bits and pieces which you had to pull together. Thank you so much for that amazing presentation. Again, because again, we're running a little bit, behind, but we will take, I'll take a couple of questions. Let me just see. There were quite a few questions. One of them was in the setting of low GFR, Sam, does the calculated, the calcium creatinine ratio can be reliably calculated?
No, it's not very reliable in renal failure. You often get a inappropriately low result. Yeah.
Okay, yeah, which is I think pretty much common sense there. Then there was this question about I presume this is what you call idiopathic hyperparathyroidism. How do you investigate patients with normal calcium, normal vitamin D, with mildly raised PTH 2 to 3 times higher than normal? The person is asking whether would you do all the urinary calcium studies?
Yeah, if you suspect normal calcemic hyperparathyroidism, you could really look at phosphate. Phosphate is a useful marker of PTH action. So with a normal calcium and a high PTH, really you need to decide whether this patient has got secondary hyperparathyroidism or normal calcemic tertiary hyperparathyroidism. It's not easy. You have to look for causes for secondary hyperparathyroidism. You mentioned the vitamin D was normal renal function. The patient is on medication, showed that bisphosphonate and denosumab even can increase the PTH. So can loop diuretics in some cases. So you have to exclude all those as causes for secondary hyperparathyroidism. And then if you suspect normal calcemic primary hyperparathyroidism, you can investigate further.
Okay, yeah. So definitely the urinary calcium study. I mean, make sure that there's no hypercalciuria accounting for it, right? Then what about? We kind of talked about it, Sam, before this seminar. Actually, 24-hour urine volume. So. The role of an adequate urinary volume in when you're doing these calculations.
Oh yeah, if you're calculating, if you are just doing a 24-hour collection, the accuracy of collection is very important. If you're going to do calcium creatinine clearance ratio, so basically if you're going to have the serum and urine calcium and creatinine in the equation, then the volume doesn't affect it. Ideally, you should try and limit it to 24 hours because all the validation studies for the 24-hour collection calculations were based on 24-hour collection. But if you have got the creatinine in serum and urine, it will correct for each other, and then you will get a reasonably good answer. So if it's just a 24-hour urine calcium or urine phosphate, and you're comparing it with the reference interval for 24-hour calcium or 24-hour urine, then you can be misled by an incorrect collection. We usually measure creatinine in the 24-hour collection, and that will give you some idea if it's a short collection, or in some cases, we get 3 or 4 liters of urine and the creatinine is very high, above the reference interval for 24-hour collection. And that gives you an idea that it is an over collection, unless the patient is a bodybuilder or taking creatine supplement. So those are problems. But if you're doing calcium creatinine clearance ratio, or even for TMP-GFR, I mean, we don't use 24-hour urine for that. It's just a spot urine. But if it's calcium creatinine clearance ratio, they should correct for each other. It's not ideal, but correct for each other.
Okay. And then one final question before I kind of go on to the challenging cases and picking the bone brains here. So Dr. Chu, I presume, is from Singapore. He thanks you for a wonderful presentation, Sam. And his question is on phosphate in the urine. So he is asking what the additional advantage or clinical value is in calculating renal phosphate handling in addition to the fractional excretion of phosphate and hypophosphatemia, as both values will be low in renal phosphate wasting. Actually, fractional excretion of phosphate will be high, I guess. So is there any additional advantage of doing TMP, GFR and all that in addition to just maybe doing a fractional excretion of phosphate?
Yeah, no, there's no additional advantage. TMP, GFR is done on spot urine, and we provide it as a standard test part of the profile. They both give you similar information, slightly different calculations. But TMP-GFR is commonly used in our country and in publications. So I think it's more popular in the bone field than phosphate clearance. I wonder what Etienne thinks. What do you use?
Yes, I'm also using TMP-GFR. Yes, I agree with you, Sam. Yeah, sure.
Okay, now, I mean, because I get muddled up in all this, let me see now whether I can share my screen. I am terrible at these kind of things. Okay, here we go. Can my slides be seen?
Yep.
It can. Okay, slideshow from beginning. Okay, so I mean, I just kind of pulled together a couple of cases which I have been stumped by over the last several, actually, one of them has been, I've been chewing over it for the last couple of years. So very quickly, I'll sum the case up. I'm not going to go into the extensive detail, but essentially this is a perplexing PTH values in hypercalcemia. So this is actually a 77-year-old Chinese lady with hypercalcemia. Serum calcium measured multiple times was elevated. The latest was 3.01 millimoles per liter, the reference being 2.09 to 2.46. Her IPTH values, her intact PTH values were low at 2 labs, okay? One of them was on a Beckman DXL and the other one was on a Roche E170. and elevated at another, where they use the Abbott architect assay. Her PTH RP levels are low, her 25D levels are normal, her serum phosphate is low, and 125D levels are also normal. So this when essentially this is a lady with hypercalcemia with low PTH or suppressed PTH at 2 labs, but an elevated PTH at another lab, along with the hypercalcemia. Her ultrasound parathyroid did show a left superior parathyroid adenoma, and I personally did the ultrasound, so I can confirm that I did see a little adenoma. But she declined a sesame B scan, and she declined any further investigation. She's not on any supplements, including biotin. She has no contact with any goats or any other animals. Her multiple myeloma panel was negative. So this is what I mean. I'm not a biochemist, not a chemical pathologist. So from what I understood, this was a summary of the labs which we were provided with. We had it repeated, at these 2 labs. So as you can see on the Beckman DXL and on the Roche, which is Beckman DXL was our hospital, and the Roche East 170 was another hospital in Singapore. At both places, the IPTH was low, 0.8. The reference ranges you can see there 0.8 and 1.25 respectively at the two labs. Whereas in the Abbott architect, which was hospital C, along with the hypercalcemia, her PTH levels were raised. So we were thinking whether there could be interfering antibody. We didn't know what was going on. So the pathologist very kindly kind of helped us do all these. And so because there was this concern about interfering antibodies or assay interference, so we did serial dilutions as well as looking for HBT, heterophilic antibodies. And these are the results, Sam and Etienne, what you see here. So serial dilution at the Beckman DXL, which is our hospital, and at the other hospital, Abbott Architect, where the elevated PTH was seen. And there was no evidence of macro PTH either. So then that's where we are. I mean, and we really don't know. I mean, because she refuses a sesame B scan, we really can't do any further investigations, and she doesn't want to kind of, one answer would be to kind of, one way to find out whether she really has primary hyperparathyroidism or not, and is to go in and operate, but of course she refuses that. So we have this issue of low PTH at 2 hospitals, at the machines in 2 hospitals, and in high PTH at another hospital. So which one is correct is the question. So the pathologist, after doing all these tests, they said there's no obvious evidence of assay interference that could account for the different IPTH values. Neither does there appear to be macro PTH. And we were thinking of whether it would be a hook effect, like you see with prolactin. And but they said the hook effect was excluded by the lack of an increase in PTH level on dilutions of the patient's serum. So then we sent off, to the Mayo Clinic, because they offer the liquid chromatography mass spectrometry at the Mayo Clinic. And there too, just like at our hospital and hospital B, the PTH, but this PTH 1 to 84, was actually low, less than 50 picograms per ml. And they reported that there were no C or N terminal peptides for wild type PTH observed, whatever that is. So, so this is just describing what our pathologists kind of did. So this is where we are, Etienne and Sam. So could I have your thoughts on this, and how should we proceed?
So thank you for showing us this very interesting and complicated case, Manju, and I'm not sure that we could provide a definite answer on this. First, this is typically a case where the collaboration between clinician and lab people is mandatory to And so I'm very happy that you had and this communication with the pathologist, and I'm very pleased also to see all the things that have been done. I mean, it's amazing. So checking with another method, checking for heterotrophic breaking tubes, which are more which can see if there are interference, of course, more for anti-mouse antibody, but also goat, but not maybe to this extent. Check rheumatoid factor, make dilutions, send it to a thermas. I mean, this is this patient has a lot of chance to have you as a physician, because this is amazing. So now, being said, this is really changing, because if you believe the Beckman or the Roche say, then you will be looking for a non-paralytic cause of this hypercalcemia, whereas if you believe the Abbott architect say, you will be checking for primary hyperparathyroidism, just like you did, and then this is really challenging. In what I would have done, but with my with what I have in my hands here in Liège, I would have checked with a third generation PTH assay. For sure. So that does measure the 1 to 84 and see what's going on with the 1 to 84 PTH, which I think might give you the same results as Beckman or Roche say. So then the question is, what is giving the signal with the Abbott architect assay, which is recognized as being PTH, which does not seem to be 1 to 84 PTH, since the Mayo Clinic did not measure it, but which could be giving a signal to be active on the receptor, because the patient is hypercalcemic. So but you can have, so this could be a PTH like what PTH post-translational modification of PTH, which is recognized by the Abbott architect, but not by the Beckman and the Roche assay. For the Beckman is very similar to the Roche assay, and I know that the Roche assay recognized a more distal epitope in the N-terminal part of the peptide, compared to the Abbott architect, which recognize a more proximal part of the peptide. So these antibodies do not really cross-react do not recognize exactly the same part of the peptide, but of course they've got both the C-terminal assay, but the amino-terminal assay is located in a different part. So you might have some kind of post-translational modification which prevents the Roche antibody to bind this post-translational medication. But the Abbott architect being more distal, you might have we might recognize this post-translational modification. So this is a clear. There is a clear interest in doing, for instance, a high resolution mass spectrometry, where basically that's what we do here, is that you take the kit of Abbott, you take the magnetic beads, and you take the antibodies, then you incubate. So the antibodies, the Abbott antibodies would incubate, and we capture this PTH, and then we will perform a high resolution mass spectrometry to see what's going on. But this is quite a sophisticated approach. But this case is really challenging. And at first time I would do a third generation PTH assay. If I confirm Beckman and Roche, it means that Abbott either is recognizing it has interference, but your pathologist has excluded it, or it recognizes something that has a PTH action because your patient is hypercalcemic, but it's not recognized by the other antibodies. That's a bit long answer. I'm sorry, but this is a very complex case.
I know. So, I mean, very stupid, dumb question. I mean, so you said high resolution mass spectroscopy, right? That's not the same. Spectrometry. That's not the same as this liquid chromatography mass spectrometry, which Mayo Clinic lab performed. Okay. So
they might. I don't know exactly if they use the Norby trap, they could do also high resolution mass spectrometry, but I don't know exactly what stands for no C or N-terminal peptides with wild-type PTH observed. This is something that they might have done, but I don't know if they had an enrichment with the the Abbott antibodies if they took the migration, because if they enrich with the Abbott, I don't know what they did, but I know that they've got that they publish a high resolution mass spectrometry, which has by the way
So
quite
different.
a high limit of quantification at 50 picogram per ml.
And the next question, so again another stupid question, the amino PTH which you're talking about is not the same as this N-terminal peptide, right? That's a completely, you're talking about a completely
I agree.
different
The semantic when the authors describe it or call it amino PTH, I don't know. Well, the semantics is a bit a pity, but it's the amino PTH is supposed to be 184 PTH, but which is phosphorylated in the serine in position 17. Why they call it amino, no idea. But it has the first, the biological activity of the PTH is linked to the first 4 amino acids or 4 or 5 amino acids, and this is a complete active peptide, but phosphorylated in the position 17 on the serine. Yeah, but here I know that the Abbott should not recognize the amino PTH because but the Roche could. So here, if what we find is similar to amino PTH, but it's not amino PTH because it would not have been recognized by the Abbott.
Okay. And so then if I may sum up what you're saying is, one, you would go for a 3rd generation assay. We would try to get a 3rd generation assay done. And 2 is check for amino PTH, which
check not especially amino PTH, but check for a post translationally modified PTH.
Okay. And so now our pathologists here, I think one of them is actually in the audience. I wish we could unmute him and kind of get him on, but I think that's impossible. But one of the suggestions was made about PTH gene sequencing. Would you think that could help?
Yes, this is also a good suggestion. Yes,
okay.
We've got something that is giving a signal. As long as you have excluded all interferences, we've got something that gives a signal, which is recognized by some antibodies but not others, and which gives a biological activity of the peptide because the patient is hypercalcemic. So this is a good approach. Yes.
And mouse antibodies, another suggestion was made for checking for mouse, and because goat antibodies were kind of ruled out, but I don't know all the animals which kind of come into play, but what about mouse antibodies? Any role for that?
So still there, if you consider mouse antibodies, means that it's more you consider an interference with the Roche assay, which use most monoclonal antibodies, but if you've got mouse antibodies, well, I would have, with this case, if I'm considering antibodies, I would say, well, listen, they might be goat antibodies in the patients instead of mouse antibodies. If the mouse antibodies would bind I don't know. I mean, this is something that can be done. I mean, you can incubate the serum of the patient with mouse serum and see what's going on. If there are mouse antibodies in the patient, I've already had this experience, and we published also a case similar like this. But if you've got most antibodies, well, in my experience, you would have increased value and not decreased values, at least in a sandwich assay. In a competition assay, it could be different. But this is so unusual case that I believe that everything should be tested to sort that out. Yes.
Okay. Yeah. Just throw everything at that. And I'm primarily a clinician, and so I had come across this. This is what I was going to do. I mean, try to put her on a trial of cinacalcet, because I came across a couple of reports in which cinacalcet was used, and if the calcium decreased, because cinacalcet is a calcium sensing receptor agent, so if the calcium levels decrease on cinacalcet, that could indicate that this is a PTH mediated hypercalcemia. So okay, they are very complicated. We have been chewing over this for the last 2-3 years actually. So I mean, just for sorry,
I'm sorry, Manju, did you measure the 125 or so? I don't remember if
125 D levels were normal. 125 D levels were normal. So PTH RP levels were normal. So that's how we first started, because at our hospital the PTH levels were low, right? So we were thinking that this is a PTH RP mediated hypercalcemia. So we we measured PTH-RP that was low, 125D levels were normal. So I kind of put together a few, etiologies of primary hyperparathyroidism with low or low normal PTH level, but I guess I'll add the post-translational modification, which to that. So I came across these in vitro, the PTH immunometric assay, which you're talking about the antibodies, I guess, right? And the hook effect, which we kind of ruled out. Pulsatile secretion of PTH was kind of mentioned in some place, but I don't think that's a problem here. And mutations of PTH that can change an epitope recognized by an antibody in the two-site PTH assay, but does not affect binding or activation of the PTH receptor. So I guess that PTH sequencing might help in that situation. And this is what you were talking about, right? The post-translational modification of PTH that affects assay recognition and an unmeasured but biologically active PTH fragment. Okay, great. I mean, but thank you for those suggestions. And Sam, I'm sorry.
I would be happy to, if this was possible. I can measure PTH here in my lab with 10 different immunoassays. So it would be already interesting to see what is giving, what give. Of course, I've got the Beckman, the Roche, the Siemens, I've got the Abbott, I've got all those immunoassays, second and third generations, and see what's going on, and also the HRMS. And would also be, I've got some tricky mixtures that we build ourselves to test for interference. So I would be more than happy if I could have, if I could
okay,
play
wonderful.
with this.
Sure, I'll take you up on that offer. We'll see if we can get that serum across to you one of these days, Etienne. Thank you so much. Okay, and Sam, any additional comments, Sam?
No, thank you. I think that's an exhaustive answer. So.
Okay, great. Okay, so the next case, which is even more tricky, and so this is okay. So final suggestions. This was by clinical pathology for us. Now the next case is actually another case that I've been chewing over. I mean, I run this complicated metabolic bone disease clinic at Singapore General Hospital, and sometimes, I mean, I claim myself as if I mean, I don't claim any expertise in this, and but I do get these referrals from all over. And sometimes I sit and, I'm stumped, they're really, really complicated. So this is actually a 66-year-old Chinese male with elevated 25D levels, and he has a history of nephrocalcinosis. His serum adjusted for albumin calcium was 2.65 millimoles per liter, just about the upper limit of normal. He's not on any calcium or vitamin D supplements. His serum PTH was normal, 1 picomoles per liter. PTH-RP was normal. 25 hydroxy vitamin D3, which was repeated twice on a tandem mass spec, I'm sorry, 25, it was 136 nanograms per ml and 150 nanograms per ml. And so because our tandem mass spec, I mean, has got a at SGH, has got at SGH meaning Singapore General Hospital, has got a positive bias. So I went back to the old kind of assay, the radio immunoassay, diasorin immunoassay at another lab. Also, it was elevated at 149 nanograms per ml. So actually, this patient was first seen by a rheumatologist, and she messaged me saying that, hey, Manju, I mean, is there anything wrong with our vitamin D assay in our lab? I mean, because I keep getting these very high levels of vitamin D3. His 24-hour urine calcium was elevated at 8.6 millimoles per day. 125D, ours, we unfortunately cannot, we do not measure 125D at SGH, at our hospital. And so we sent out to Mayo Clinic, and it was also elevated at 140 picograms per ml, or 337 picomoles per liter, the normal range being 18 to 64 picograms per ml. There's no evidence of sarcoidosis, no evidence of TB or other granulomatous diseases clinically or radiologically. His serum ACE levels were normal. So because I too, Etienne, I mean, I have come across this whole thing about CYP24A1 deficiency. And so I was like convinced that this is what, the patient had. And so I sent to Mayo Clinic, and indeed, the 25D is to 24, 25 dihydroxy vitamin D ratio was 41.55. I mean, it was not the VMR which was calculated, but this particular ratio was 41.55. His 25 hydroxy D2 was less than 4 nanograms per ml. 25 D3 was elevated again, there too at 145 nanogram per ml. And Mayo Clinic sent back a note saying ratios of 25D is to 24-25 dihydroxy vitamin D in the 25 to 80 range can be seen in patients with either low vitamin D levels or heterozygous CYP24A1 mutations, which went with my earlier test suspicion that that's what he had. But then I sent for a genetic analysis, and I said actually it was an NGS panel. There was no mutation detected in any of the nephrolithiasis gene panel offered by, it was a commercial lab called Invitae, including the CYP24A1 gene. So what do I do is the question. So
well,
this clinically, he walked, talked, and quacked like a CYP24A1 deficiency, but the genetic test was negative.
Well, exactly. And also, yes, nephrocalcinosis that you mentioned. So you've got
exactly
unexplained high 25 RCD, unexplained high 125, the non-detectable 24-25. This is clearly for me, this person does not metabolize the vitamin D. So I don't know with the lab. I mean, if you've got the clinical data
sure.
and the analytic, the biological results go in the same direction. So here I personally would not really so much put so much confidence or too much belief in the genetic analysis, because yes, and what you could do also is maybe check if this patient has got family, also has got children or parents.
And so very interestingly, I mean, he doesn't, so I checked back, I mean, it was, I mean, so he comes from, there is a possible history of consanguinity in the family, because he's an immigrant. His parents or his grandparents actually migrated from this very tiny village in China, I mean, it's very tiny, and he doesn't know the history, but he thinks that likely his grandparents were first cousins. So there is a history of consanguinity also in the family. So that was why I was convinced that this was, definitely, a CYP24A1 deficiency.
And does this person have children that could also be tested?
They haven't been tested, but his son has a history of nephrocalcinosis too, if I remember correctly. Yeah.
So there is probably something very interesting to investigate there, and and there is for sure there is a genetic trait, but I don't know. I mean, I would, if I had to do something again, I would check again the genetic analysis and also check this in all the family to see if they have the same phenotype, at least with vitamin D. And of course, if you tell me that the son has got nephrocalcinosis, that's it. I mean, because there is, of course, there is this this transmission of the disease between the family. And we had exactly a similar case to this one. I presented it during my vitamin D presentation.
Exactly.
And we put, and he had also a pulmonary affection, and the patient, I suggested to treat the patient with rifampicin and stop supplementing with vitamin D. And now the person is perfectly right, but we identified 2 mutations in this person.
Yeah. So, and I in fact was thinking that I would, when before the genetic test came back, I was thinking that I would kind of consider starting him on rifampicin. And for people in the audience who probably, I think you didn't really mention what the role of rifampicin here is, Etienne, so maybe you could kind of describe it, that alternate pathway.
Yes. So rifampicin is activating cytochrome P450 pathway, which allows another degradation of vitamin D, not using the CYP24A1. So it's an alternative which is not very active, but it can be stimulated by rifampicin, and this is really a new way to degrade the vitamin D. So there was a paper publishing this in patient, and I was suggested to the clinician to to put the patient on rifampicin, that she agreed, and so that we had good result with this. So it's activation of another pathway of degradation of vitamin D.
I mean, I was really on the brink of starting him on rifampicin, but then I thought, okay, let me get the genetic test done, and then the genetic test came back, and I was like, oh my God, why did I send for the genetic test? But okay, so I think, I mean, those were the two kind of, very challenging cases that I thought that I would kind of bring up in this discussion. So we are perfectly on time. I think we have answered most of the questions in the Q&A box.
I reply to some of the questions.
Yeah, and I know I saw I answered a few as well as Sam and Etienne. So I think, let me see, just make sure that
maybe to answer Dr. Shu, I'm not sure that PTHRP can be detected by any immunoassays for PTH. I think it's the first part of the peptide is similar, but the rest is totally different. So I don't think that PTHRP can be detected by some assays, but not by others.
Oh, okay. So I think the audience, the Q&A box is set that only the person who asked the question can see the question and the answer. So maybe I'll read this question out.
I'm sorry.
I presume Dr. Chu is referring to the first case in which he said, thank you for a very interesting case. I wonder if PTHRP may be a consideration. Would PTHRP be detected by some assay and not by others? So, and you're saying unlikely, right?
No, unlikely, yes.
Okay,
yes.
okay. I think we kind of answered most of the questions. I personally have a ton more of other questions, but I think I'll pick your brains privately, both of yours. So I think it's my duty now to thank these two amazing friends and colleagues of mine who in such a short span of time, and literally I kind of asked them a month ago, I think, because when I first brought this up, and in this short period of time, they managed to kind of put together these incredible presentations, which I'm sure has been very useful for all of us. So thank you very much from the bottom of my heart, both Etienne and Sam. And I also would like to thank a few people, including Events 360, which is actually the secretariat, which has been behind, helping me with this setting up this webinar. And also, I would like to thank my tiny little osteoporosis and bone metabolism unit. We are a very small little unit, but I would like to thank Dr. Ann Kui, who is my colleague, as well as my two osteoporosis nurse clinicians, Huang Xiaofeng and Liu Xiaoming, who, I mean, let me do all these kind of crazy things. They kind of pick up all the slack, and they let me do these kind of crazy things, and I would like to thank them too. So with that, I think I will draw this webinar to a close, and we have recorded this, and we will try and get this recording available to people. We haven't yet decided how we're going to send the recording, but most probably it'll be published on my Asia Pacific Consortium and Osteoporosis website and LinkedIn page. So a little shout out to that too. So thank you very much, all of you, for spending this evening with us. And thank you again, Sam and Etienne.